during the early stages of brain development or immediately after a trauma to the brain, but it happens throughout the lifespan, but it decreases over age as we go. Where does it happen? It usually happens in the areas adjoining the brain areas, the opposite hemisphere in the same area, or by strengthening old circuits and leading to peripheral connections. So just to give you a little graphical presentation, that this is the potential of brain growth over the years. As you can see, it actually starts antenatally. And the potential is maximum in the antenatal and the first 1 year of life. You peak maximum by about 4 to 5 years of age. And then from 5 years to adult life, the growth is relatively less. This was a lovely example of a single child who they scanned from the age of 5 till the age of 20. And they did his magnetic resonance imaging with functionality. And they studied the different regions which light up at different stages. And what you can see is in the earlier stages, the motor function is significantly more important with the red signing. And as you go further, the prefrontal cortex, the parietal lobes, etc., become more increased, indication, executive function, emotional development, and then visuospatial, which improves over a period of time. So you can see the growth and the potential that happens. This is the sensitive period from the low to the high that is there. And these are the different types of development which take place over. So we have a peak, whatever the type of development, you can see that there is a huge peak in the 0 to 4 year age group. And then from the 4.5 roughly to 7 or 8, everything comes down to a plateau phase. And then it becomes smaller and smaller as it goes, whether it is numbers, whether it's social skills, language development, symbolic correlation, vision, habitual responding, hearing, or emotional control. And this is, again, those critical periods when they happen. Motor development actually happens prior to conception. Language starts a little bit before. Social attachment and skills are very important in the first few years. Vision is very particularly in the first year. So it's very important to do that ophthalmic examination in the first year and get the eyes checked properly, because you see that the potential for development growth is relatively lower as you go by. And peer and social skills is something that comes as time goes by, which has an environmental and a family component to the underlying genetic components. So how would I, if I wanted to improve the plasticity of the brain, how would you do it? You would carve out a new pathway. So you teach the child something. You teach the child something in an environment which is charged and emotional. Okay, so you strengthen these pathways, which is there. But when you teach, you need to teach with passion. You need to be something that the child focuses on particularly. You repeat it again and again and again and again over a period of time. You make that little road into a little thicker road. It's become a pathway. That pathway then becomes a highway. Once you've made it a highway, you know that whatever you do, even if you drop off after a certain period of time, that circuit is laid down. It is laid down for life, and the child will remember those aspects going forward. So it's very important that thought or the feeling, it is repetitive, creation of a new neural pathway, which is communication, which takes place. The third is repetition of it, and then you strengthen it by repeating it again and again. And it needs to be done in a space where you are focused with attention and passion. How do children learn like that if you look at it? So you just see, this is the first time you learn something, you forget almost 20% of it within 24 hours or 1 day. Then you learn it a second time, you forget 20% in 3 days' time or 2 days' time. Then you learn it a third time, you forget 20% in 3 days' time. So that's the concept of repetition. That's the concept of physiotherapy. That's the concept of all our rehabilitation, is by doing it again and again, I will lay down a circuit in the brain. Once that circuit is laid, that circuit will hopefully stay there for life and the child will get the benefit. So what influences plasticity? You have things like sensory and motor input, psychoactive drugs, hormones, parent-child relationships, peer relationships, stress, intestinal flora, the food you eat, diet, and exercise. So one of the nice ones is stress. We always tell our kids, don't stress. And we all tell ourselves, oh, I'm really stressed out. But stress has plus and minus. Stress can be good for us and stress can be bad for us. So when your stress levels are really low and you're bordering on boredom and depression, then the attention increases. You are actually in your maximum potential of learning when you are at a minimum amount of stress. The minute the stress becomes too much, it leads to anxiety. And then when the stress is over the margins, it leads to a meltdown. So this is the person who is bored and calm, which is there. This is the person who's distressed because of breakdown. And this is the area in which the brain maximizes its learning process. A little bit of stress is very good for the learning system. The next one is exercise, as we say. So this is a very nice diagram of which you can see graphical representation of someone sitting quietly, and after 20 minutes of exercise, activation of brain circuits or brain areas. And it doesn't take much. It's just 20 minutes of walking. So when you say, these were done in students when they were asked to do the same test. So a little bit of activity and exercise. After you come back, you'll feel your brain is far more charged and much better to learn at that stage. Love and neglect. So this is scans to show institutional children and never been institutionalized. And you can see that those who get the love have far more active circuits on their brain, because love, or an emotional quotient which goes with it, enhances learning and development of brain circuits. And likewise, love is one part, stimulation of the brain. So a child who doesn't get stimulated versus a child who gets stimulated. So stimulation in any forms, usually through any of the senses that we have, vision, auditory, touch, smell, taste, balance, any of those stimuli, you will see that the child learns in a more engaging fashion. So this is math grade. So this is a little bit after intervention. So what we call a little early intervention, stimulation, putting the child on the right track. You see those children who learn with a little stimulation or intervention learn much better than those whose scores showed a decline over a period of time where they were not taught in a stimulating or in a happy space. There is good role for meditation, and this is also where the concept of yoga and yoga helping in the meditation and intellectual capacity. So whichever type of meditation, they've shown clearly that calming the mind and focusing your energies helps to reinforce circuitry in the brain, versus if you're just doing it in a haphazard or doing it without the ability to focus your mind centric. Sleep. We have no idea how important sleep is for children as well as for adults. So you can see those who have good sleep, this is how they fare in their syllabus going forward, and those who have persistently awake late into the night because of their exams and studies. We need to try and understand and teach our children from before that sleep is far more important. And if you sleep well, retaining capacity is much better, as against if you stay late into the night and try and read and study all night long. So these are the hours of sleep that we really need. And when you start in the first few months, it's as much as 14 to 17 hours. Then when you go from the 6 years, when they go to school, it should be 9 to 11 hours. When they go into higher school, it should be 8 to 10. You drop to 7 to 9 by about 25 years of age. So till you finish your 10th and 12th and children are with us, they should be getting 8 to 10 hours. And the likes of all of us, whatever our age is, we need to get minimum 7 and ideally 9 hours of sleep every night. So this is what happens by repetition. You see the concept of repetition. So this is the negative side of repetition. You see the ad every day and you just get fixated on it. You can see the whole family has got fixated on the stimulus, the visual stimulus of a concept, and they all do the same. Food. Food is a very important integral part of brain development. So you have something called stunting in children. So what is a stunted brain this is, and these are the areas they've seen. The sub-Saharan belt has a little bit, India has a little, large parts of Africa and East Asia also have a little, and some parts of South America as well. And that is, you grow up with less nutrition, your circuits in the brain do not get the elemental vitamins and minerals that they require. They are not working as best performance. When you get education, you do not reach your maximum potential. Because you haven't reached your maximum potential, your professional life and your future has not reached its maximum. You don't get the best job that you could have had if you had to. And likewise, you go into early child labor, early children, more children, etc. And then this vicious cycle continues due to the lack of nutrition. So this is mental stunting rather than physical stunting. And unfortunately for us, financial aspect definitely does play on the brain, because all the things that I've given to you from the nutritional part of you, the degree of the stimulation that you give to the child, if they get compromised in some way, the brain's development also gets compromised over a period of time. So drugs, we think it's not just what it does to the physical being, it also affects the brain. And you can see that certain parts of the brain get permanently damaged with those who are on chronic drug abuse. So circuits get damaged and poor circuits don't get laid, particularly parents on drugs, mothers on drug during the pregnancy, and children over a period of time. Circuits can get affected. Physical ability and physical weight as well is a concern which is there, because the heavier the weight, the endocrine and hormonal changes which happen also affect brain development over a period of time. So briefly to tell you that 82% of the brain development has happened by the age of 3 to 5 years of age. There are some lovely books if any of you are interested in looking up, because it gives you an idea that the importance of brain development. And honestly, there is a lovely book which has just come out, which if any of you could read, and that is a generation, anxious generation. It's a lovely book called The Anxious Generation, and the role of what computers and electronics is doing to the brain's development and the neuroplasticity of the child because of exposure to tech such a young age. So this is a nice graph to show that how the brain really learns. You learn maximum in the first few years, and then you peter down. You never stop learning. The likes of you and I are also still learning, but the effort that it takes to do this learning exponentially increases to achieve the same amount of learning. And the sad part is all governments do this. They spend all their money in the later half of learning when the child goes to college, post-grad, they give you scholarships, they do all that, whereas they spend nothing in the pre-primary age group or in the primary years, whereas the maximum brain development, this is the age where the government should be ideally spending maximum monetary support to awaken the brain to have the love for learning and the love to develop. So the takeaways on this is it's real. It grows maximum in the first few years. Multiple factors affect it. The desire to learn under repetition and assimilation in a positive, stimulated, nurturing atmosphere are key to laying down new circuits. And do remember, though it happens maximum in infancy and the first few years, it's always never too late to learn. So we now go on to a little bit on the cases that we see. This is the spectrum of cases that we see in pediatric neurology. If you to break it up, a large chunk of it is still cerebral palsy. A large amount is developmental disorders. About 26% of it is epilepsy. A small percentage are all the other concerns. But you can see from the spectrum from infection, migraine, metabolic, movement, neurocutaneous, neuromuscular, oncology, and structural, we have a relatively similar range as against adults, but neurodegenerative is big in pediatrics. Oncology is a different type of category, and metabolic disorders is more in pediatrics because they are usually genetic by nature and they manifest a little earlier. So just a little bit of quick stuff. The seizure, it's an acute clinical change due to an abnormal neuronal discharge. You all are familiar with that. An epilepsy or two or more unprovoked seizures more than 24 hours apart, which is a tendency to have epilepsy. And situation-related or acute symptomatic epilepsy are seizures which are either provoked by illness, metabolic, toxic, injury, hurt, damage. It does not denote an epileptic tendency. So one event of a seizure which is due to something that you could identify, it becomes a symptomatic seizure. So what are the provoking? Why is it important? The provoking factors for an acute symptomatic are usually fever, injury, electrolyte, infection, stroke, drugs, etc. The risk of getting epilepsy is 3 to 10%, which is the natural risk of epilepsy in the general population. Whereas if you have epilepsy, means a tendency to have 2 or more seizures over a period of time, the provoking factor for those are usually sleep deprivation, psychological stress, extremes of emotion, happy, sad, scared, fearful, emotional, fatigue, infections, or a family history, and the risk of having repeated seizures goes as high as 50 to 70%. So if an event is ambiguous, it is better to wait for the recurrence for clarification. Do remember, I would rather wait and get another seizure and be sure that this child has epilepsy and then start treating him rather than label him as epileptic when he is not, because that label and that stigma, though it may be better today than it was maybe 20, 30 years ago, is still a huge stigma for children with epilepsy. Febrile seizures, you're all very aware of. 6 to 6 months. Duration should be less than 15 minutes. Semiology, generalized tonic-clonic, no postictal deficit. There's no evidence of an underlying CNS infection, metabolic abnormality, or preceding history of afebrile seizures. And the treatment is usually the treatment of the underlying cause of the fever, whether it's a ear infection, throat infection, gastroinfection, etc. Seizure control can be done by immediate benzodiazepines, either the midazolam or they come into the hospital, lorazepam. And neither continuous medication nor intermittent anticonvulsive therapy is recommended for children with simple febrile. So one, you can give them fever medication. You can teach them what to do when it comes immediately the next time. So see that you're ready as soon as the child is warm. You can give the fever medication, keep the temperature down to prevent the seizure. Must investigate. Now I've got my first seizure. Now it's not a febrile convulsion. It came without fever. Out here, there's actually no need for any investigation.
Anaita, you've gone mute.
Can you see me and hear me?
Yes, we can now.
Sorry, my connection broke for 2 seconds. Sorry for that. Okay, so the febrile, we discussed with you, the febrile seizures, no need to investigate, no role for an EEG, no role for an MRI if it's a typical febrile seizure, no role for anticonvulsant therapy. And though many people do give clobazam for 2 or 3 days during the febrile illness, by evidence-based medicine, there is really no role even for the clobazam during the febrile episode. So the next one comes to the first unprovoked seizure, okay, which ideally is a seizure where you have no provocation. There was no fever, no injury, no infection, no anything. The only investigation you really need to do for any of these children is an EEG. Ideally, if you can do it 2 to 3 days after the seizure is over, because you don't get false positive reports with focal slowing. The other stuff, the lab investigations, neuroimaging, the CSF, etc., are usually optional investigations depending on the age of the child and depending on what is the precipitating factor or what is the situation in which the child had the seizure. What are the chances in your what are the things that may predict recurrence? If you have an EEG abnormality, if the EEG is abnormal, you will go for neuroimaging. If your neuroimaging is abnormal, if you have abnormal neurological examination, and if your etiology is something which you know has caused damage to the brain or the chance of causing damage going forward, you know that the chances of getting epilepsy down the line is distinctly much higher. So we can't go into the details, and I think Dr. Pradnya will be going more into the epilepsy, but I'm just giving you the brief overview. These are the multiple drugs that are available today as anti-epileptic drugs for children with epilepsy. These are the conventional old standard drugs that we all knew. There's a host of newer drugs which are there now. The nice part is they're slowly becoming sensitive to children, and we are getting more syrups available. We are getting more IV preparations available so that the spectrum of choice of drug is there. There are new drugs in the market, and there are some other drugs which we can use as adjuncts, which also work as drugs, such as the ketogenic diet, steroids, etc. So how do you choose that first drug? The first is the efficacy and the effective. The most important, you want it to work. And then the next most important thing is you want it to be tolerable. So your efficacy is tested from the time of the first seizure till the child is actually been seizure free after that. And tolerability is once you've started treatment, the first side effect of it or indicates that the child is not tolerating it, and then we may have to switch accordingly. So what in the treatment options do you have? If you've started the first anti-epileptic, they say 50% of children will benefit with any first anti-epileptic. Any, okay? This was a nice study done. They chose any drug which was over there, and 50% of people who were going to be responders responded to the any drug that was given. The remaining 50, when they added a second drug, 13% responded. When they added a third drug, only 1% responded. After that, they went to another combination of 2, only 3% responded. And when they went to a combination of 3, 0% responded. Meaning, your best chance of controlling the epilepsy is with the first drug that you put on. Second best chance is with the second drug that you put on. And by adding more and more medication, you do not necessarily mean you will control the seizures that easily. Okay, and drugs for focal or generalized that we have for generalized seizures, the drugs of choice, which was done by a survey of pediatric neurologists to see what they prefer. And these are the drugs, valproate, levetiracetam, lamotrigine, topiramate. These are what you call broad spectrum anti-epileptics, like you have broad spectrum antibiotics. And for absent seizures, we now get ethosuximide, which you can use. And for focal seizures, the carbamazepine, oxcarbazepine, and then the broad spectrum drugs again. Very important thing that every patient should teach every doctor should teach their patient is how to use the midazolam spray. You shake it, you first prime it, that you do one puff in the air to see that the hole is open and the spray is coming, and then you administer it. And that dose is dependent on the weight of the child and the age of the child. So we're not going to go into more because this will happen. So if you start with monotherapy, you start a second monotherapy. If not, you may try a third mono, or you'll go to combination therapy. You may try 2 or 3 combinations. If not, you will go into the more aggressive treatment options, and you will start looking at stuff like the ketogenic diet, surgical workup, or the vagal nerve stimulation. So we have a 15-month-old girl of a third-degree consanguineous marriage with normal birth and development till 1 year of age. And she had regression of milestones after an acute respiratory infection. She had frequent falls, abnormal gait. She was sitting with support, but she was very, very irritable. So her gait had gone down, but her support was there, but there was a cranky, irritable nature. There was no history of language or cognitive regression or seizures. She was conscious, she was irritable, she had no cranial nerve involvement, she was ataxic, her tone was normal in all 4 limbs, her reflexes were normal, and her plantars were flexor. When I investigated her as a neuroregression secondary to an acute respiratory infection, we found that her lactate was elevated. The rest, her CSF and serum evaluation was relatively normal. So when we worked her up, you could see that she had significant MRI changes, which you can see in the caudate and the putamen of the basal ganglia. These were the features that she had with an abnormal spectroscopy. At that time, I didn't know what I was looking. She sounded like a mitochondrial disorder. We pulsed her with methylprednisolone because we weren't sure whether she was an autoimmune. We gave her the entire mitochondrial cocktail because genetics and lab reports take time to come by, and we can't afford to lose precious time because time is brain. On day 3 of the treatment of that, she started walking again and without support, and she was still ataxic. This is her repeat MRI 6 months later. Everything had cleared out over a period of time. And in those days, it used to take me 3 to 4 months to get a genetic report. She turned out to be a thiamine metabolism dysfunction. Both parents were asymptomatic. This child was what you call biotin thiamine encephalopathy, where she had an encephalopathic picture, regression of milestones, basal ganglia involvement. When you see regression, you have to think metabolic, you have to think genetic, and you have to work really fast, because if you can correct it rapidly, sometimes with a broad treatment umbrella, you might get a good change and a long-term picture. This is a 2.5-year-old boy of a child of a consanguineous marriage, normal birth history, had seizures on day 2 of life. He had been given multiple anti-seizure medication and he was not improving. He was discharged at home and sent home on day 15. He came to us at 6 months with multiple seizures and developmental delay. He had been given a trial of pyridoxine, and on that, dramatically improved in the seizures within days. He gradually improved in his milestone, but he has mild autistic features. And whenever the parents stop or miss a medication, they have recurrence of seizures. So this was his EEG in the neonatal period or in the infancy period. And this was 6 months or a few weeks after the treatment of the pyridoxine. And you can see the dramatic change after the pyridoxine. And do remember, whatever age you add the pyridoxine, the child benefits with it significantly. But ideally, it should have been given in the newborn period. The child has a genetic deletion for pyridoxine deficiency. And as a result, this is one of those conditions where you're required to give pyridoxine lifelong, and you need to give a higher dose in the newborn period. Then you bring down the dose as the child grows older, and they can turn out absolutely normal if identified early and treated correctly. So these are the treatments for pyridoxine dependency. We would do a CSF, we do bloods, we send up the genetic testing. We load with 100 milligram of pyridoxine. We don't routinely get the IV, though some people can source it in some places, but even a 100 milligram tablet will take a little time to act, a day or two, but it will work. You monitor the EEG and you'll see the changes. Then you maintain him on a lower dose. You send off the genetics. In stressful periods, double dose during the fever. Don't overdose, because sensory neuropathy is a side effect of too much of pyridoxine. And then you maintain him over a period of days. So these are a few vitamins which are very important, can be life-changing for children with epilepsy in the early months or years of life, namely pyridoxine. They can manifest with different types of seizures. They respond to even a small dose. Biotin, something like biotinidase deficiency. So biotin thiamine. So ideally plain biotinidase. These are the symptoms that you get with it. You treat it with biotin 5 to 10 milligram per day, every day, again, lifelong. And biotin thiamine, where you give a combination of biotin and thiamine to these children, like the child I showed you before, who come in a more regressive type of a picture, and they also respond beautifully if identified. So my take home for here is that if you get children with seizures which are intractable in the infancy period, even before you start investigating and sending off genetics and metabolics or whatever, you send off a critical sample, you'll send EEG and MRI, and you start them on this multivitamin cocktail for a short period of time till you get all your reports back. You either confirm your diagnosis or you disapprove the diagnosis, and we move forward after that. So again, a small child who came with multiple episodes of paroxysmal movements on day 10 of life, staring look with clonic jerks of one or more both limbs, followed by uprolling, fluttering, subsiding on its own within minutes. I hope the video plays, yes. And you can see that in children, you have different types. Here, you've got the jerking, which is there. He's got uprolling, which is happening. The left side has now started jerking. First, it was the right side which was jerking. Now the right is jerking again. So in newborn or paraneonates, you get a whole host of different type of movements when they have seizures. They don't necessarily seize like you and I would with regular jerks of the arms and legs. Okay, at this time, he was hypertonic. His head circumference was otherwise okay. He had fisting. He had incomplete Moros. He was treated with levetiracetam, phenobarbital, which are both the drugs of choice in the neonatal period, but there was no improvement at all. They gave him a trial of pyridoxine and biotin, which I taught you just now. Again, no improvement at all. So that was his EEG, where he has rhythmic buildup of electrical activity. And then we thought that we have nothing on his MRI. He was not responding to the regular drugs. He's not responding to the vitamin supplements. Maybe I'm looking at a genetic epilepsy in this child. And if I have a genetic epilepsy, there are certain things we need to remember. We need to choose our drugs very carefully. So we put him on phenytoin, everything settled. But we were already 1 month too late. And in that 1 month, the circuits in the brain had developed to such an extent or got damaged because of the chronic epilepsy to such an extent that the child had permanent motor delay, autistic features, and a global developmental regression. So this is a little sodium channel drug. So depending on the genes, what I'm not going to go into the detail, but my concern is once you know what gene you are dealing with, you know what drug to choose. So the gene doesn't just tell you that I'm a genetic epilepsy or I'm a metabolic disorder or I'm a neurodegenerative. Today, genetics actually tells us what drugs we can use. Is there any drug which is not in the regular epilepsy market drug that I can use for this particular type of thing? Is there anything happening on gene therapy? How do I counsel the parent? How do I go forward? And obviously, antenatally, how do I protect that family going forward? So depending on what gene I have, depending on what time of life I started my seizures, it tells me whether I'm what you call a gain of function or a loss of function. And in the bargain, I know which drugs to choose for these children. So honestly, any of these children who have epilepsy in the first 6 months of life, we do not sit a single day. We refer them as soon as possible to a specialist, because choosing the right drug as early as possible can change the life of that child, instead of waiting 2 to 3 months, failing 2 to 3 drugs, and then sending him to a specialist. Okay, so these are a few things that you can learn. These are genes. If I have this gene, I avoid these drugs. If I have that gene, I will give high dose. If I have another gene, I will think of ketogenic. If I have PRRT, I will think of carbamazepine. PRRT is a movement disorder, a gene, and it has a little epilepsy, but the anti-epileptic can work on it. Then we've discussed pyridoxine. We have different ones, and then obviously the tuberous sclerosis if we have. So seizure control and thus development of some epileptic encephalopathies can be life-changing if we know how to choose the correct drug. A 45-day-old baby, if you look at his skin lesions, I'm sure most of you recognize immediately. He was diagnosed as tuberous sclerosis. He was given a trial of vigabatrin. He had no seizures after that, and his development was normal. And this was his EEG before. These are the tubers that he had in the heart antenatally. These are the tubers you can see in his brain over here, a large tuber that he has. So this is one condition, only one condition, where you can give an anti-epileptic drug as prevention of seizures, because they've said that if your EEG starts showing discharges, even in the absence of seizures, if you give vigabatrin, it is a disease-modifying drug, and that child may not get seizures. And if he does not get seizures, he may have a better chance of a normal life going forward. So this is one condition that if you have a family history, or if you pick up those lesions on the child as early as possible, or antenatally, the 2D echo shows you that I have tubers and the pregnancy has gone through, see that you monitor his EEG regularly so you can start the treatment early. Again, I would say this child needs to be referred to a higher center for early intervention. So in tuberous, early treatment with vigabatrin for EEG abnormalities is protective. It's effective on epilepsy and neurodevelopmental disorders. So this was a 10-year-old girl. Sorry. So this was a 10-year-old girl with normal birth and development. She came to the OPD immediately in the post-COVID lockdown with inability to bear weight on her limbs. She could not walk properly. She had this hopping. If you look carefully, it was almost hopping and flaying of one side, but really the arm was being used more to balance herself because she had become ataxic. As a result, she had stopped going out. She did not go to school. She stopped playing with her friends because she couldn't walk. And if you see down the line, she had an MRI, which was normal. Her evoked potentials, her SSEPs were mildly prolonged. Her baseline chemistry showed that she had a vitamin B12, in case you can't see, was 92, which was severely deficient. Okay, so she was treated with IV and oral B12 supplementation, and every 7 days, this is the course, followed by every week for 3 weeks, followed by every month for 6 months. That's the full B12 deficiency treatment protocol. Her gait improvement, she could walk with her school bag. She was back in school within a period of a few days. This is a 20-year-old male child of a third-degree consanguineous who presented at 17 years with complaints of slowly becoming slow, progressive confusion, longer time to respond, deterioration in gait. Came to me in a wheelchair many months or years after the onset of his program. His MMSE score was 10/30. He was dysarthric. He had no cranial nerve or cerebellar signs, but he had no hand function, severe spasticity, brisk reflexes, extensor plantars, and I got a strong posterior column or prolonged latencies on his posterior column involvement. And his younger sister had had similar complaints. She had been normal till 10 years. She had regressed. And unfortunately, she had passed away over a period of time, and she had no drug ingestion, visual difficulties, or any of the other features. And this was his MRI for a 17-year-old boy. Let me tell you, this is severe cortical atrophy. Normally, this age, your brain should be fully formed. The ventricles are up. The cortex is atrophic. And he was evaluated for a neurodegenerative disorder. And what we got is his homocysteine was 299. And he turned out to be an MTHFR homozygous deficiency. Now, MTHFR is a relatively common condition in the Indian population. Many of us are carriers. That means we
Madam, voice is not coming.
Gamut of everything. Why? Sorry, can you hear me? Can you hear me?
Yes, yes, yes.
Yes.
So MTHFR, though common in the Indian population, homozygous will be degenerative and life-threatening. Heterozygous, we need to check our homocysteine levels and monitoring because we are prone to strokes with it. Okay, so this is something we need to check. So what does B12 give us? B12 gives us a whole spectrum of low mood, apathy, sensory motor neuropathy, posterior column involvement, hyperpigmentation, neuropsychiatry, anemia, and it's very common amongst vegetarians. So we recommend that all vegetarians should ideally be on long-term B12 supplementation. Wide spectrum of clinical features. It can manifest as low mood, low energy, long time for deficiency to appear, prolonged period for recovery, hyperpigmented knuckles is there, and you will require injectables in the acute phase. Oral supplementation takes very long for you to reach, almost 6 months for you to reach the levels. So the only way to treat it is first IV followed by oral supplement. So it's important to check homocysteine and B12 in neurological conditions. And we routinely ask for B12 and homocysteine in every child who comes into our OPD when we ask for biochemistry. Because something you don't want to miss, it's easily treatable and it can have long-term effects on numerous systems in the body. So I think this is the last set of cases that we have. This is a set of 3 children. The first is a 14-year-old boy of a consanguineous marriage with developmental delay since birth, abnormal movements, hypotonia, drooling, dystonia, and a sibling which was similarly affected. He was being treated as cerebral palsy for the last so many years, and he was on physiotherapy, occupational therapy, oromotor speech therapy, and going to schooling, special schooling. 4-year-old male child with developmental delay noted at 7 months by the parents when he didn't sit properly, then came to sitting with support after therapy. He had tightness of all his limbs. His cognition was normal. He was attending school. He has spasticity, dystonia, brisk reflexes, again, cerebral palsy, and was going to rehab for many months and years. And a 6-year-old boy of a 3rd-degree consanguineous with delayed development, constipation, microcephaly, minimum activity, motor delay severe. He only rolled over at 1 year, sat at 2 years, cognition was delayed, and he had brisk reflexes. So you have spasticity and all, you have cerebral palsy in all of them, and they were treated with rehabilitation in each case. But the important thing was the MRI was normal in all of them. Okay, and there was no significant birth-related history in most of them. So clinically referred to me as cerebral palsy, and it just keeps going. Known case of cerebral palsy, going for therapy, whatever it is, and MRI was normal with no distinct perinatal problems. So this child, dystonia with movement disorder with a normal cognition, MRI was normal. We gave him Syndopa and his genetics were sent. He can walk independently and his dystonia has settled. And when we sent his genetics, he turned out to be a DOPA-responsive dystonia. This was his gene, the SPR gene, and he had 2 siblings which were affected that going forward. The second child had spasticity with brisk reflexes. When we did the MRI, brain was normal, but when we did the cervical spine, we found that he had atlantoaxial dislocation with compression of the cervicomedullary junction. The foramen magnum was decompressed, the C1 laminectomy was done, and the child going forward was able to walk with support, and otherwise he had not walked for a long period of time, and he was being treated as a CP and just sitting otherwise. And this last child had a head circumference with lethargy, large tongue, coarse faces, short stature. We did his TSH, simple thing like TSH, and he had congenital hypothyroidism, and this was his condition. And then once he was treated, he benefited. However, we had already lost that window period of helping him from brain development. So it is interesting to note that 10 to 18% who are treated as cerebral palsy are really not cerebral palsy. They are something else that are being missed as cerebral palsy. And once they get into that rehab cycle, it just keeps going. And parents think their child have motor delay and it's cerebral palsy, but really we need to do a little testing. So who would you suspect might not have cerebral palsy and might have something else? If the child has hypotonia, if he has dysmorphic features, if his MRI looks normal in spite of whatever they've been treating him as CP all this while, if he has a positive family history or a sibling who's also affected, if he has no perinatal insult, he's cried at birth, discharged by the mother's side, feeding established early, condition at discharge was otherwise relatively good, you need to go back. Or if he has a consanguineous marriage, indicating I might be sitting on a genetic predisposition, these are the ones who you need to think may not be CP, and you need to look and work them up otherwise. So the last two slides are just little quick take-homes that make your life easier. Pediatric migraine, the drug of choice is not propranolol. The drug of choice is not sodium valproate, topiramate, etc., etc. It is flunarizine. Flunarizine is the drug of choice for pediatric migraine. It does not work as well in adult migraine. Once they cross the 15-year barrier, I would consider treating them like adults. But flunarizine needs to be given for at least 10 to 15 days before you can seek significant changes. So if they come back to you in a week and they tell you the headache is not gone, don't worry, tell them to continue the medication. It takes at least 15 days for it to kick in before you can say the drug is not working. Flunarizine side effect makes you sleepy and hungry. They put on weight, so only a night dose preferably and as low as possible so as not to have weight gain. Topiramate is an anti-epileptic drug which is very often maligned because it has side effects such as temperature, word finding difficulty, renal calculi. The one that you need to remember is the temperature. Very often a child on topiramate will come back to you with temperature treated for infection, X-ray done, sonography done, gastric testing done, everything done, counts repeated 3-4 times, blood cultures done, but they can't find why this child is got a temperature. The only thing you need to do is cut the dose of topiramate or increase your fluid intake, particularly in summer months. That's one side effect you must keep in mind. Phenobarbital, still a very good anti-epileptic, often maligned for this hyperactive component part of it. But do remember, when you take off phenobarbital, it takes 5 to 10 days for it to get excreted out of the system. And you need to cautiously monitor the child, particularly post-op and surgical. They may be drowsy and sleepy longer, and you start thinking it's some CNS problem, and really it's just the drug which is taking longer to come out of the system. The newer drugs for dystonia, gabapentin is an excellent drug for pediatric and adult dystonia. It not only works on the dystonia, it also works on the sensory aspect as well as the pain part, particularly children with CP. As they go into adult age, they have severe pain. Gabapentin is an excellent drug. Arcamine or clonidine is an excellent drug for both dystonia as well as for hyperactivity. It causes significant drowsiness, to try and give it in the nighttime as much as possible, but it's very safe. It does not produce BP fluctuations or hypotension, so you can comfortably use it in the pediatric age group. And riboflavin has to be kept in mind in mitochondrial chain disorders. Now the drug is easily available in the country. So far it wasn't available. We had to import it if necessary. Now it is available. And the last one is the role of plasmapheresis. We always think in GBS, it's only IVIG, but plasmapheresis is a very good alternative for children with GBS. It is routinely done in children today. So once you have referred them or you're managing them, IVIG is one option. The next option would be plasmapheresis in the newborn. So in conclusion, neuroplasticity is real, and the time to focus is the first few years of life. Okay, repetition in a focused, happy, congenial, attentive environment, and we learn for the rest of our life, not just in the beginning, but remember the first few years are very important. And that is why early intervention is the keystone or the cornerstone for any conditions, be it treating cerebral palsy, be it treating epilepsy. The faster you correct something, the circuits improve and the brain is protected. Early developmental regression, seizures, abnormal movements. Remember the vitamins we told you, thiamine, biotin, pyridoxine. These are the important ones that we could give even before a diagnosis comes in so that we don't miss treating these conditions. B12 and homocysteine should be a part of all routine neurology biochemistry. Even if you are not suspecting it, please do it. Correcting B12 can make a world of a difference to mood, behavior, temperament, and a host of other neurological issues. Early referencing, understanding genetic function. If you understand how the gene works, then we do the correct treatment, we do the correct, we recommend to the correct specialist. Today, with the role of gene therapy and higher level treatments, we are on top of the game where we work fast, we work early, and we give the most appropriate management. Tuberous sclerosis, an early diagnosis and early reference, early treatment can change the child's future. If a young child comes to you with seizures, please remember to take off the clothes so that you look for the ash leaf macules, you look for the shagreen patches. We cannot afford to miss this diagnosis at any cost. And the statistics show that 1 in 5 children with cerebral palsy might be a genetic etiology, not just a genetic or a degenerative etiology. They might have genes which predispose them to CP. It's because of that gene the child didn't cry at birth. Because they didn't cry at birth, he then got the cerebral palsy. So it's the gene that gives you the CP and the gene that predisposes you to the CP. So a review of history and clinical features, look for the red flags, either investigate or refer as soon as possible. With that, I'm going to stop and we go to the next session. I'm happy to take any questions now or subsequently.
Madam, genetics takes how long time?
Pardon?
Genetics testing takes how much time for reports?
The genetic report usually takes about a month. When genetics started, madam, it used to take me 6 months, then it became 3 months, then it became 2 months. Now it's become a month, and very soon it's going to be 15 days. Genetics is a tool you have to be a little careful with. We cannot loosely investigate with genetics because sometimes to pick up something which is not expected also needs to be very careful. So we need to know why we are asking for it, what we aim to achieve by asking for the genetic testing. And once we get it, we need to know how to interpret it and how to maximize the information we have for treatment.
Okay, now which labs are reliable for genetics testing? Everyone does it.
So there are many labs which are available, and many of our Indian labs are also good. We have a host of them. I would say Centogene, which is a German lab, may be one of the best, but they're still expensive. MedGenome is there, Strand is there, Newberg is there, Lilac is there, a whole load of other genes. So it's not just, how I choose the genetic lab. I choose it depending on who gives me answers when I ask questions. So if that report, I need help with it and I need to understand it, and I can pick up the phone and speak to the clinical geneticist and get a better understanding, that is the lab you should look at, because they are able to give you more information than what the report normally says.
Okay, thank you.
We'll take the rest of the questions at the end of the sessions. Thank you, Dr. Anaita, for this exhaustive topic. Our next speaker is Dr. Pradnya Gadgil, who is Senior Consultant Pediatric Neurologist and Complex Epileptologist. Her topic for today is Treatable Scenarios in Pediatric Complex Epilepsy. Good afternoon, everyone. Just going to share screen. Can you see my PowerPoint and can you hear me?
Yes, ma'am.
Yes. Thank you so much. Good afternoon. Big thanks for the attendance. Anaita's given a fantastic, exhaustive talk regarding the treatable scenarios in pediatric neurology as a whole. Now we're going to try and focus. The next two talks will sort of focus on more specific scenarios within neurology. I think epilepsy probably is one of the commonest symptoms that we see in pediatric neurology. So let's have a look at how would you manage patients
who have epilepsy. Anaita has again talked a lot about that. But let us see, how do we manage patients who have complex epilepsy? So the outline of the talk is...
Ma'am, it's in presenter view. Can we make it full screen?
Oh, I see. Okay. One second. It's going to presenter only. One second. Is the presenter view off? It's at least off for me.
Yes.
Thanks. Thank you so
Yes,
much.
ma'am.
Thank you. So what we will look at in this talk is the concept of medically refractory epilepsy and why is it important to address this. I'm going to briefly touch upon the role of precision medicine in the context of epilepsy. Then, honestly, precision medicine is a vast subject. So today I'm going to talk about one arm of precision medicine, which is epilepsy surgery. And again, try and get the concepts across of how epilepsy surgery is different and what are the epilepsies which are surgically remediable. And with that context, I think I'll quickly go to cases and hopefully leave all of us with a very practical approach, saying who are the patients who do need this extra inputs from a multidisciplinary. So what is complex epilepsy? Typically, epilepsy which does not come under control with anti-seizure medications is thought of as complex epilepsy. But it's not only the seizures. The minute we use the word epilepsy, all we think about or all that we are conveying to the families, to other doctors, is that we are only thinking about the seizures. But honestly, complex epilepsy, yes, have uncontrolled seizures and form about 30 to 40% of all the epilepsies that we see. But overall, it's much more than uncontrolled seizures. The main worry around complex epilepsy is the cognitive hit that the brain takes. And then when this cognitive hit is taken by the brain in a very young age, it makes it even more devastating from a future perspective for the child. Of course, epilepsy is already a big social issue in our country. So if a child or an adult, for that matter, has uncontrolled seizures, then they are functioning at a lower at a lower level, almost cognitive level. They're possibly not developing as well as they should, and there is a problem with social integration of this child. So big problem, and the problem is much more than just uncontrolled seizures. What causes complex epilepsy? Very many reasons. It's a very heterogeneous condition. But broadly speaking, the causes are structural, as in either malformations in the brain or acquired brain injury, or a whole lot of genetic conditions, genes which cause a difficult to control epilepsy. So the ideal treatment, given how difficult this clinical syndrome is of complex epilepsy, ideal is a precision medicine approach. So let's have a look at what precision medicine is. But before that, a typical question is, which I honestly very often get asked by my patients in clinic, the parents, saying, "Madam, why don't you just try one more anti-seizure medication? दो से काम नहीं हुआ, चार से काम नहीं हुआ. Why can't we write one more? Aren't there any more anti-seizure medications?" This is real world data around the efficacy of anti-seizure medications. Anaita has already covered a part of this. We know that almost 50% of epilepsies will get well controlled with the first anti-seizure medication. But thereafter, of the remaining, about 30% get controlled with the second anti-seizure medication. But thereafter, the efficacy of anti-seizure medication drops precipitously. So from those 40s and 30s, the chance that a third anti-seizure medication will make a difference drops to less than 10%. And the fourth and the fifth, the possibility of those being effective reduces exponentially. And why is that? I mean, why don't anti-seizure medications work? But that's because we know that there's a fundamental limitation. As the nomenclature says, these are anti-seizure medications. They're designed to only to be able to suppress seizures. They're not designed to be anti-epileptogenic. So there is a 30-40% of the substrate of epilepsy etiologies which do not lend themselves to be controlled by anti-seizure medications. And these are the ones which are the difficult complex epilepsies, which we are talking about today. So have we not been doing precision medicine all this while? I think we possibly, the answer is yes and no. And I'll sort of tell you why. So epilepsy overall is a clinical diagnosis. We know that very well. They are well-defined disorders. A child has 2 or more seizures. You call it, diagnose it as epilepsy, and then you look at the etiology and the neurology of it. But then, when you start treatment, the feel of it is largely empirical. You might do a little bit of precision medicine with respect to focal seizures or generalized seizure, narrow spectrum anti-seizure medication or a broad spectrum anti-seizure medication. But thereafter, when one fails and the second fails, then you are trying this. Oh, does perampanel work better in myoclonic or does it not? Does CBD oil work better? We always have pharma reps coming and talking to us saying there's a new drug on the block. But overall, that choice feels very empirical. And that is because the understanding as to what really causes epileptogenesis overall is very, very poor. We genuinely do not understand how epileptogenesis happens in certain brains. But nobody has really looked at the genes of the common benign childhood epilepsy syndromes like the childhood absence, Rolandic epilepsy, which we call SELECT right now. There are certain genes identified which cause a SELECT-like syndrome, but then we don't know all the genes. So why do certain patients, there are families where the gene will be positive, but only some patients get epilepsy. There are children who have acquired brain injury. Some may get no seizure at all in their life, despite them having periventricular leukomalacia, and some have normal MRIs and still have a difficult epilepsy. So we just do not understand the mechanisms underlying epileptogenesis in the real sense of the word. So it's not surprising that treatment feels empirical. However, we, like I said, to an element, we do try and practice precision medicine, such as if it's a focal epilepsy, use a narrow spectrum anti-seizure medication. If it's childhood absence, use ethosuximide, and so on. So we've been doing a bit of precision medicine approach thus far, but we've been limited by the poor understanding of the underlying mechanisms. Has that changed? It has changed with epilepsy genetics coming in. Just if you need numbers, till a couple of years ago, more than 1,500 genes were identified to be associated with epilepsy, of which almost 170 genes had their main presenting symptom of their clinical phenotype as epilepsy. And the worrying thing is, a lot of them were associated with what we call an epileptic encephalopathy, which means, yes, there is epilepsy, but there's significant associated neurological comorbidity. Out of these, just about 5% of the genes are allowing us to have potential targets within them with respect to their molecular mechanisms or the protein that they end up, the mutated protein that they end up producing to be a treatment target. Okay, for example, PRRT2 or the mTORopathies, if it's a gene which affects the mTOR pathway, then you know that an mTOR inhibitor might help that disease. A great example is tuberous sclerosis. But for the precision medicine to become omnipresent from a pharmacological perspective, I think we still have a long way to go. However, we are now very actively, I know Anaita's talk even ended with a question around genetics. So we are very actively trying to do genetics so that if there is an opportunity for precision medicine, then we want to try and use it. Okay. With that, I'm going to move to the second aspect of precision medicine in complex epilepsy, that is epilepsy surgery. Now, I get asked this question very, very often. What is epilepsy surgery? This is precision medicine for epilepsy, which is secondary to a structural malformation in the brain, a structural malformation or an acquired brain injury, basically a structural cause of the epilepsy. Is it a new technique or a strategy? Not at all. This was conceptualized as early as 1816s. Euglin Jackson is called as a founder of modern epileptology. And he with Victor Horsley, both British doctors, performed the first epilepsy surgery in late 1800s at Queen Square Institute of Neurology in London. Remember, forget MRI. They did the first epilepsy surgery even before the advent of EEG. The EEG wasn't invented till then, but they were already doing epilepsy surgery. So how were they trying to do that? That is because epilepsy surgery is fundamentally a functional neurosurgery. It's not the typical neurosurgery where you see a tumor or you see a bleed in the brain and the neurosurgeon is going after that, or they do a MRI of the spine and they see a prolapsed disc and the surgeon is going to go in and repair the disc. No. Epilepsy surgery is a functional neurosurgery because you are actually chasing an epileptic network, which may or may not have a lesion associated with it. And I'll try and explain this in the next few slides. How does this concept of functional neurosurgery come up? That is because we know that the brain literally runs on electrical networks, and some of those networks become epileptic or are epileptic, and hence the patient experiences the clinical epileptic seizures. Now, it depends how are these networks placed topographically. So in some patients, the networks are localized to a one area. Sometimes there is only one network. And if we are able to see that in a given patient, the network is only in one area of the brain, even better if it's only one network in one area of the brain, and that's been consistent through the epilepsy journey of that patient, then it's very intuitive that if we remove that network, and of course, to remove anything, you would need epilepsy surgery. And of course, epilepsy surgery is not only invasive, and we will come to that. There are different types of epilepsy surgeries. But in some or the other way, if we ablate this network or get rid of this network, the epilepsy would get resolved. That's the concept of a functional neurosurgery, that you're chasing a network rather than chasing a particular geographical or a 3D lesion. Now, very often, thankfully, what happens is these networks closely correlate with lesions. So you might see a gliosis, you might see a cortical malformation, you might see benign tumors, which correlate with the clinical epileptology part of it. But then we equally have patients where we do not see a lesion. Now, some of them may be genetic, some of them have lesions which are too subtle to pick up on epilepsy protocol MRIs, but the network is very much there. And so epilepsy surgery is a game of trying to understand that network and trying to understand, are we going to be able to get rid or resolve that network safely and successfully? And the ones where we think that's possible, those are the patients who have what we call surgically remediable epilepsies. So if this was complex, an even easier way to understand this is, there is tissue in the brain that's epileptogenic. Typically, more often than not, it usually has no great function, but it could. If you remove this one way or the other, the chance for seizure freedom can be very, very high. Some surgeries give you a chance of freedom of as high as 90-95%, and some sort of plateau at about 50%. But all of that would depend on what is the type of the lesion. Is it one lesion? Is it multiple lesion? Are we doing a limited surgery because there is eloquent cortex, and so on and so forth? And I will try and exemplify that in the cases to come. But if you remember the earlier slide, the chance of a fourth anti-seizure medicine working was about 5%. And any epilepsy surgery, the chance at a minimum is about 50% and could be as high as 90-95%. So it's very intuitive that if you have a patient who continues to have ongoing epilepsy, despite the correct anti-seizure medications been given, deserves to have a look at saying, does that child have a surgically remediable epilepsy? Is there something else that we can do for this child to improve the epilepsy journey? But the neurosurgery, is it dangerous? Is it difficult? Epilepsy surgery, I have to say, is a subset of neurosurgery, which is probably the safest. And there are two big reasons for it. One is in a given patient, it's an elective surgery. The pre-surgical evaluation, which I'll come to, is very detailed. So there is great, very detailed planning that happens before going into the epilepsy surgery. Then secondly, the concept of epilepsy surgery is as old as the late 1800s. So the concept has grown, surgical techniques have become more robust. The complications encountered around the way have been dealt with respect to the surgical techniques. For example, the way hemispherotomies would be done a few years ago and the way they are done now is very different. So the designing is fantastic overall. And then for a given patient, it's not an emergency procedure. It's looked at, planned out very, very carefully. Lot of tech is used in it, and that makes the risk of complications very, very low. So it's a treatment strategy which makes a big difference, way more, has a potential of making a huger difference than any additional anti-seizure medication in the complex epilepsy experience of the patient at a very low risk of complications. And what we aim and do is try to remove the epileptic network. We don't necessarily chase lesions all the time. So now, with this context, how do we do it? Like I said, these are patients who are very, very well studied. By well studied, I mean they undergo a very detailed pre-surgical evaluation. The pre-surgical evaluation, the essential elements are a prolonged video EEG. By a prolonged video EEG, I mean a video EEG long enough for us to be able to record the usual seizures that the child is experiencing. Then a very high quality, different kind of an MRI. We call it a harness protocol and epilepsy protocol MRI. And neuropsychology. These are the minimum basics that every patient who is being taught or being considered as to he or she is a candidate for epilepsy surgery should undergo. There should be no exceptions to these three basic tests. Then some patients need additional tests. If we need to understand the function or if we need to understand the network better, then there are functional studies like PET scans, SPECT studies. There is intraoperative monitoring, and I hope to show you examples of a few. Sometimes even this doesn't help, and we need to do two-stage surgeries in which we stereotactically implant electrodes. But all this is being done to sort of understand, is there an epileptic network that can be addressed, and can it be addressed in a safe manner? These are the two questions that we're trying to answer basis of pre-surgical evaluation. So the essential elements are common for all patients, but whether we need additional tests is tailored to each patient. There's a big teamwork that's needed in the whole thing. Now, the pre-surgical evaluation is a misnomer because remember, sometimes a pre-surgical evaluation may actually rule out a certain type of surgery for a given patient. For example, if there is a patient who has bilateral hypoglycemic brain injury, and you see that the seizures are coming from both the posterior quadrants independently, then he may not be a candidate for a curative surgery, but then he might be a candidate for a neuromodulator surgery. Okay. So it's not necessary that every pre-surgical evaluation will result in a specific type of surgery, but it's important to put every patient through that process so that you are at least able to pick out the ones who have surgically remediable epilepsy. Okay. How do we, it needs two things. It needs skill sets. It needs a big team. It needs a functional neurosurgeon. And thankfully, I think Dr. Saurav talks after me and he will talk about this. It needs a whole team of neuropsychologists. It needs neurophysiologists. Of course, it needs neurologists. So it needs a big team to pull this through. And it needs a lot of technology. It needs quite a different level of imaging studies. It needs intraoperative monitoring, which is done for different reasons. The surgeons need extra tools such as neuronavigation. Sometimes we end up doing awake surgery. Sometimes we end up putting stereo EEG electrodes into the patient's brain and recording them. So we need the tech and we need the skill sets. Okay. And this is what, we don't need this in every patient, but we need everything available because you never know which patient is going to need more for us to be able to say, is there really an epileptic network that we can remove safely in a given child? Okay. So with this context, I'm now going to show you a couple of cases to sort of exemplify the theory that we've been discussing thus far. So the first case, this is a 6.5-year-old boy. He started having seizures when he was 4 days old. 4 days old. Now, I'm sure the pediatricians here and the general practitioners would think, is this hypoxic injury and so on and so forth. So all that got looked at. So there was no immediate reason for this child to have seizures. So they were not acute symptomatic seizures. They were very early onset epilepsy, starting on day 4 of life. Okay. The minute you have this history, you and I know that you are dealing with either a genetic epilepsy, which starts off very early in life, or it's a cortical malformation. And the clinical journey will then help us to sort of differentiate between the two. Then the other thing that happened was early right-handedness. So we know now that in pediatrics, early handedness, if a child exhibits handedness before 18 months of age, it's actually a sign of a focal neurological deficit. Okay, so that means that there's something not quite right with his right hemisphere. Okay. And this child then continued to have incessant seizures despite multiple anti-seizure medications. So he had a medically refractory epilepsy, i.e. a complex epilepsy. He would get daily seizures, 6 to 8 every day, in sleep, in awake. As he got older, he said, oh, I feel the seizure coming on. And then he would go to the parents. He would say, I'm getting a seizure. But then he would be unresponsive. Then he would have a face pull to one side, to the left side. Then the left side of his body would have tonic posturing, brief events, and he would snap out of the seizure. So you already have great clinical information here, which is helping you to take the disease to the right hemisphere. What is helping you? The fact that he has early right-handedness, and now you have these motor features in the seizure, which is again taking you to the right hemisphere. It's a focal seizure because he has an aura, he reports the seizure and then becomes unresponsive. So this is a focal seizure with impaired awareness with motor features, focal motor features. So that again takes you to the right frontal lobe. Okay. And this is all clinical. Okay. Initially, his milestones were okay, but now the seizures are such that he is not able to attend school. When seizures increase, when they become 10, 12, 15 a day, he visibly slows down. He looks slow. He's not able to answer quickly. His gait becomes unsteady. So he probably keeps entering into what we call an epileptic encephalopathy, which is both motor and cognitive, because his gait gets affected and his cognition gets affected. When there are days and weeks when the seizures are better controlled, this is better. Okay. So you can see the cognitive hit again just on history that this epilepsy is lending. So he has a clinical syndrome of a medically refractory focal epilepsy with an element of cognitive and motor worsening, most probably coming from the right front. Okay. So then you do an MRI. Because you're localizing it to the right side. As it happens, we typically will get patients who already have had MRIs. So in this MRI, this is an eggshell T2 weighted image of the brain, and you can see it's marked that there is a clear area which looks very different on the right side in the frontal lobe, just ahead of the central sulcus. It looks very different from the left hemisphere. So what is this? This is a cortical malformation. It's called a focal cortical dysplasia. Now everything fits in. All data is concordant. This is a malformation, means he was born with it. That explains the fact that he started having seizures from day 4 of life. We know that the seizures, which are typically secondary to focal cortical dysplasias, are medically refractory. So there you are. He's medically refractory. He's early right-handedness because you had an abnormal right hemisphere. So the handedness became apparent very early. And then the motor features of the seizure also takes you to where the lesion is, to the right front. Okay. So you have very, very concordant data. Even then, this patient undergoes the pre-surgical evaluation. So we bring him in, we review the medical history, we localize it basis the clinical history. Then we recorded 14 seizures in 24 hours on full medications, and everything localized to the right frontal, most likely to the SMA region. That explains the dystonic posturing. The MRI, which was already done, showed a right frontal focal cortical dysplasia. His IQ as of now was normal, but he kept having these periods where he would cognitively worsen when the seizures would go up. So this was a case which is a great, nice example of what we call a surgically remediable epilepsy. Because if that focal cortical dysplasia is removed, what we've demonstrated from the clinical history and the video EG is that the epileptic network is sitting in that focal cortical dysplasia. So if we request our surgeon to remove that, then the chance that this child will be completely disease-free or seizure-free is very, very, very high. Okay. However, there's a problem. One thing is, will he be free of epilepsy? But the other question always is it going to be safe to remove it? Now, we know that this focal cortical dysplasia is likely in the SMA, which means it's very close to the motor cortex. So the resection carries a very high risk of hemiparesis. I want to bring to your notice that these dysplasias are not like tumors. You do see them on MRI, but when the neurosurgeon does the craniotomy and opens the dura and you see the brain where the dysplasia is, the naked eye cannot tell which is the dysplastic cortex. Okay, which is why you need all those extra infrastructural aspects in the OR to take you to the right place of the focal cortical dysplasia. Okay. Then we noticed that this kid already has a little bit of mild left-handed weakness. So though the IQ is normal, he has a persistent motor deficit from that dysplasia. So we decided to do intraoperative monitoring with a view to preserve the motor eloquence. So not give him hemiparesis, but at the same time, make sure that the whole dysplasia is removed so that he becomes seizure-free. Honestly, if he was 6.5, if he was much older, we would have considered doing an awake surgery. Okay. So this MRI is the same MRI T2 axial, but now on the right-hand side of the screen, you can see the tracts, the motor tracts, and you can see how they are almost straddling the dysplasia. Okay. So one second, I'll just choose my pointer. So this is the dysplasia, and the corticospinal tracts are going right around it. And this does not, yes, it looks beautiful, colorful here on MRI, but when you open the brain, there are no different colors. There is nothing which helps the surgeon to tell these apart. So we do the surgery with a lot of intraoperative monitoring. So right now you are seeing a technique called neuronavigation, which the surgeon uses to get to the correct place accurately. And so that is the first thing we do. Then we map the central sulcus. So we map where the motor strip is. We do electrocorticography because electrocorticography is an EEG done directly on the brain. And we do it before and after. It's a little bit like in tumors in oncology. Surgeons will take a biopsy post-resection and they will wait for that fast biopsy report. The electrocorticography is something similar, but it's very live because we record the EEG straight away from the brain. And while the resection is happening, the surgeon uses a special instrument to suction out the abnormal tissue, which also helps us to continuously monitor the motor evoked potentials. Okay, and all this is done to ensure that we remove the dysplastic or the malformed cortex and we do not hurt or injure the white matter tracts with a view to not giving him additional hemiparesis. So this is the postoperative MRI. You can see that the lesion is removed and you can see that the tracts are intact. And even better, this is the video of the child when he came for follow-up for the first time. And you can see that he's actually moving his hand very well. So he's seizure-free. This is one of the early surgeries we did at SRCC. So he's seizure-free since surgery. He did not sustain any new focal neurological deficits, though we went right up to the motor cortex. And in fact, he's had no problems thereafter with schooling, with that worsening that he was having from a motor and or a cognitive perspective. Now, second case. Now, this is actually a more commoner scenario in India. 15-year-old girl. She had NICU stay for 7 days, had whatever, perinatal hypoxic insult, this, that, low sugar. So she's been living with a delay in milestones ever since. But the delay is mild. She's attending mainstream school. She's getting along. She's left-handed. She had no epilepsy till 5 years of age, but then the seizure started. And she's now 15. So for the last 10 years, she's just having consistent seizures despite trying. This patient came to us having already tried 9 anti-seizure medications. The maximum seizure-free period she had in her 15 in the 10 years of epilepsy was just 2 months. Otherwise, the seizures were just relentless. Her semiology, seizure semiology. So this is a patient where you say, yes, this is a complex epilepsy. This is medically refractory. What can I do to improve the clinical situation of this child? So you would then come to the semiology. The question you ask yourself is this a focal epilepsy or a generalized epilepsy? So the semiology of the actual seizure is that she has a sudden behavioral arrest. She becomes like a statue. Then she has hand and leg automatisms. Then she has head and eye deviation to the right side. She's unresponsive at this time. And then she snaps out in a couple of minutes. And she then herself doesn't remember the seizure. Okay. So the description of the seizure or the semiology of the seizure tells you that this is a focal unaware seizure. And it's a focal unaware seizure with actually automatisms, we call it automotor, and an element of motor features with this, in view of the head and eye deviation going to the right side. So that immediately takes you to the left side of the brain. The semiology takes you to the left side of the brain, possibly to the posterior quadrant. Okay. So again, because she is a patient with complex epilepsy, she goes through the whole gamut of the pre-surgical evaluation. She gets her video EEG done. So first, of course, is clinical history examination, video EEG, MRI, and a neuropsych examination. So yes, she has medically refractory focal epilepsy. She already had a mild right hand weakness, cannot do a lot of fine motor skills with the right hand, and is left-handed. The video EEG recorded 9 seizures in 24 hours. The semiology, the EEG, everything took us to the left posterior quadrant. So now the clinical semiology also seemed to suggest that it's on the left side. And then the EEG, the video EEG and the interictals also took us to in the left hemisphere to the back of the brain, the left posterior quadrant. The MRI showed left-sided parieto-occipital gliosis, but additionally also showed a right frontal gliosis. Okay. The neuropsychology showed that her working memory scores are low. There is parietal dysfunction, and the right hemisphere is the dominant hemisphere. So you have a huge amount of information here. The MRI shows lesions on both sides of the brain, in frontal on the right side and at the back of the brain on the left side. The experienced seizures right now that you've heard history of and that you've recorded are saying that all the epilepsy is coming between the 2 lesions. It's coming from the left side on the back of the brain. And the neuropsychology is also telling you that the right side is dominant, which means it becomes a little less likely to be epileptic. There is parietal lobe dysfunction and working memory scores are low. All of this again points to the left posterior quadrant being the main diseased quadrant. Okay. And posterior quadrant means you are worried about visual fields. The visual field perimetry shows that she already has a pre-existing quadrantopia. So very, very concordant data. If we do a disconnection surgery on the left side of the brain and the back, again, high chances of seizure freedom. In her case, the visual fields are already lost. So it's not that we would cause any additional visual field loss by performing this surgery. However, I have to say, there are patients where we do posterior quadrantic disconnections, even if they have intact visual fields, because the pros and cons are weighed. They're discussed with the family in great detail. Our post-ESM discussions with the family are detailed. We talk with the family at least twice and with the whole family to get them to understand what is it that we are about to do, especially given the fact that this is functional neurosurgery and there is very less general awareness around the concept of functional neurosurgery. Even in patients where the visual fields are intact, we have ended up doing posterior quadrantic disconnections, which do result in a visual field defect. But the patients, it's incredible how with visual rehab after the surgery, they adapt and live, and their day-to-day functional life is not affected by the visual field defect that is caused secondary to the surgery. So coming back to our case, this is the MRI. These are mainly T2 axials showing the large area of parieto-occipital gliosis on the left, and it's quite significant on the T1, and a small area of right frontal gliosis. Okay, but the right frontal gliosis does not interest us because it's not necessary that every lesion will give rise to epilepsy. Right now, we are trying to look at curing or treating her epilepsy. The epilepsy is all coming from the left posterior quadrant. So we are only going to look at that parieto-occipital gliosis on the left side. This is the tractography, and you can see that the visual tracts are already affected on the left side. You can see the right side, they're so much better. The green on the right versus the blue on the left shows that there is paucity of visual field tracts on the left side. So she undergoes a temporoparieto-occipital disconnection. These are the post-operative MRI pics which show the different steps or the elements of a temporoparieto-occipital disconnection. The first sagittal shows you the parietal disconnection. The axial also shows you the parietal as well as the occipital disconnection, and the coronal shows you the temporal disconnection. The post-op tractography also shows that the tracts have been disconnected, so it's a gray-white matter disconnection. And the reason I've put this video on is because people think, oh my God, you are taking away a quarter of the brain. How is this kid going to do? This is this girl on day 5 after the surgery. She's ready to get discharged. She's in plain clothes. She's doing absolutely fine. So these surgeries are very, very well tolerated. In fact, younger the kids, they do better. And I think my last case will show that. So this is a 5-year-old girl, normal birth history, but very early onset developmental delay. At 5 years, she's non-verbal, but she's not autistic. She uses gestures to communicate. She has no motor deficits, which are focal. She started experiencing seizures at 7 months of age. She has daily seizures in which we call these seizures drop attacks. What happens? She goes stiff, there is abduction of both the upper lips, and she falls down, especially if she's sitting or standing. She has no seizure-free days. So the last 4.5 years of life, she's been having these daily drop attacks. Someone has to be with her all the time so that she doesn't fall and injure herself. In 5 years, doctors have tried 11 anti-seizure medications, despite which she gets daily seizures. Okay, so this is a medically refractory epilepsy, a complex epilepsy. There's refractory epilepsy and there's developmental delay. But the seizure types here, as opposed to the first 2 cases, are not focal. She's having what we call tonic seizures. There are different types of drop attacks, and she has tonic seizures. So of course, they come with an MRI, and the MRI shows that she has bilateral posterior quadrantic polymicrogyria. So she has malformation on both sides of the brain. Then the seizure type is non-localizing in the sense that they're drop attacks, they're tonic. So this is fundamentally a generalized seizure. Okay. So when you have malformations on both sides of the brain, it's impossible to go and remove one and cure her of the epilepsy. That's not feasible at all. But their main problem is this falls that are happening multiple times a day, risking her safety. She can fall down and hurt and injure herself anytime. So one family member has to be her shadow. She has to be with someone all the time. Okay. So is there any way where we can better this? So this got discussed in our epilepsy surgery meeting, and there is a type of surgery called a corpus callosotomy, wherein the drop attacks magically from the next day of the surgery just stop. Okay. So we do not cure the seizures, but we stop the seizures from causing the drop attacks. Okay. So this is a anatomy specimen of the brain, and you can see the corpus callosum dissected out beautifully. That thick band between the 2 hemispheres is the corpus callosum. The drop happens because the electricity travels from right to left or vice versa. The electrical coupling happens, as they call it, and that is why the drop happens. If you are able to stop the electrical coupling, then the drop attacks stop. So it's a big surgery. You are disconnecting the 2 hemispheres from each other in some ways. Now, corpus callosum is a commissural fiber. It's a white matter tract which carries the biggest burden of epileptic discharges from one brain to another. Because we don't only have one commissure, we have multiple commissures in the brain. But the corpus callosum is the main pathway through which the epileptic discharges get shared between the two hemispheres, causing the drop attack. Corpus callosotomy is a well-described surgery designed to stop these drop attacks from happening. So this girl on day 3 of surgery is she loves Shah Rukh Khan, and this is how she's dancing on day 3 of surgery. She still has an NG in situ. Of course, she got discharged on day 5. But again, this video is to show you that despite undergoing such a major brain surgery, the recovery is so fantastic. There is the morbidity that is assumed in neurosurgery isn't as real in majority of the cases of epilepsy surgery. So with this, when do you consider putting a child through a pre-surgical evaluation? So the traditional thinking was, if 2 drugs fail, seizures are causing a lot of impairment, and there's an epileptic encephalopathy, then you have to do it. That's all correct. Okay. About 30 years ago, the ILA and the American Academy of Neurology came up with the recommendation as a standard of care for patients that every patient who has a surgically remediable epilepsy should be offered surgery at the failure of the second anti-seizure medication. But what we're seeing in India is 9 anti-seizure medications, 10 anti-seizure medications, and so on. So we really, really need to start preempting this for our patients. However, in 2022, the ILE has gone a step further. The recommendations which were earlier remain, that any patient with medically refractory epilepsy, as soon as you've determined that they are medically refractory, they are drug resistant, you have to think of offering a surgical evaluation. But they've gone one step ahead. They've said that even if patients are not medically refractory, even if they're well controlled on anti-seizure medications, but they have a type of epilepsy which can be cured by epilepsy surgery. The first case I showed you, where you could remove the lesion and render them seizure-free completely. If that is the kind of epilepsy and the etiology that the child has or the adult has, then you do not have to wait for drug refractoriness to come in. Do offer surgery, cure them of the epilepsy, and enable them to lead a normal life. So I think when to refer for epilepsy surgery has really changed from just the complex or the difficult epilepsies to saying, are they surgically remediable? Let me preempt this and put them on a fast track. Why do I talk about this so much? So at SRCC, we've been lucky to have the team that you saw in the team photo earlier, and we are the first and the only dedicated pediatric epilepsy surgery center in the country. It's a lot of credit. A big shout out goes to Anaita for her vision and leadership with this. But we are also very lucky that we've been able to put a team together. So all this was theory thus far. What is the real world data? So I'm presenting a slightly stale statistics. These are from October 25. But when we looked at our statistics when we completed 100 surgeries. Now we are at about 150. So our cohort was, we were getting very few patients early on. We were getting more patients after they were 12, 13, 14, 18, as late as 20, 21 years old with childhood onset epilepsy. Of course, all patients went the compulsory pre-surgical workup. Every single case gets discussed very systematically in a multidisciplinary case conference, which we call the epilepsy surgery meeting. It happens on a Monday morning at SRCC. So if anyone of you is keen, you're very welcome to come and attend it. We looked at what procedures we've done. So there are different surgery types, as Dr. Samantray will explain in a moment. So we did about 55 curative surgeries and 38 disease-modifying surgeries, and the rest were neuromodulatory. So we are this graphic is just to show that we are doing virtually every type of epilepsy surgery that is done across the world, with the exception of something called RNS, but that technology isn't available as of today anywhere outside North America. But otherwise, we are doing every single type of epilepsy surgery in pediatrics, that to mind you. What everyone's interested in knowing is the outcomes. So of the curative surgeries, we had almost 90% at their last follow-up. We had 90% patients who had what gets called as Engel 1 classification, which means they're either completely seizure-free or they have no disabling seizures. So almost 90% of our cohort at the last follow-up had excellent results with respect to the curative epilepsy surgeries. Then what about the so-called palliative surgeries, the corpus callosotomies, the neuromodulation? All our patients who underwent corpus callosotomy have had a complete cessation of the generalized tonic seizures or atonic seizures, drop attacks as they call it. VNS, again, we have very comparable data. We've at least had a 50% reduction. So remember the statistics I was talking about, that the epilepsy surgery gives you a chance of 50 to 95% of your reduction in seizures or complete cessation of seizures. So our statistics are very, very concordant with the world data. Complications, in those 100 surgeries, we had no mortality. We had only one patient with an unexpected permanent deficit. Of course, about 15% had minor post-op deficits like fever, SIDH, contractile neglect, aseptic meningitis, and so on. But really nothing, but these were all transient. So in summary, the kind of complex epilepsy that we treat is slightly different because we are still the developing world. We still have a challenge with problems with delivery of perinatal care. So we have a huge percentage of acquired brain injuries. So our etiologies are undoubtedly very different from the developed world. Okay. Also, a lot of the work that happens in developed world hence focuses around temporal epilepsy. Our cohort is actually extratemporal. But it's clear that we are able to deliver results which are very, very comparable to international standards, both with respect to the type of treatments that are available and our outcomes. So, as a rule, no matter where you are, any patient who has a refractory epilepsy, or you think that the patient has a surgically avoidable epilepsy, please refer that patient to a complex epilepsy center so that the test can happen to see, is there a chance of curing this patient or at least improving the seizure burden by one of the disease modifying or the palliative surgeries. Remember, we have a lot of technological advances coming at us. We are incorporating all the technological advances as will get shown in the next PowerPoint. And using all this together, like having all the skill sets and having all the toys, so to speak, in the game, it's actually possible to deliver a very safe experience to the patient. So overall, I think our case series shows that pediatric epilepsy surgery is safe with respect to morbidity, mortality. It happens because we have a team and we are very, very particular about the right patient selection. And one extra thing that has been made possible by SRCC and Narayana Health is that we are able to offer this at very, very affordable rates, because that's a third question that people always worry about. So with that, I'll end my talk. A big thank you for your attention. And I think we will take the questions at the end of the session, if I'm not wrong. Thank you.
Thank you, Doctor. Thank you, Dr. Pradnya. Our next speaker is Dr. Saurav Kumar Samantray. His topic is treatable scenarios in pediatric neurosurgery.
Good evening, everyone. So after these two intensive and interesting neurological talks, we move on to the last talk of the session, which is basically a pediatric neurosurgeon's view of the kind of conditions that we treat here in our department, in our hospital. Of course, we're a team working together, but I will try to show you some of the neurosurgical cases that we encounter and try to treat here. Sorry, yeah. So the spectrum of pediatric neurosurgery is actually quite elaborate. Like you see, the different conditions that are coming up on your screen: spinal dysraphisms, hydrocephalus, brain tumors, craniofacial anomalies, spasticity, vascular disorders, epilepsy, movement disorders, fetal neurosurgery, craniocervical junction disorders, so on and so forth. So this is all that comes under the ambit of pediatric neurosurgery. Quickly, spinal dysraphisms, all these pictures, different lumps and bumps that you see on the back, and sometimes you have a normal back with normal skin which can still harbor an underlying spinal dysraphism or a neural tube defect. Then you are very aware of this condition called hydrocephalus, which can present in various shapes and forms, which is again something that a pediatric neurosurgeon has to treat. Then there are these various types of brain tumors and spinal cord tumors that are treated by a pediatric neurosurgeon. Epilepsy surgery, like Dr. Pradnya has elaborately discussed, is again something that in the pediatric realm is dealt with by a pediatric neurosurgeon. Now, akin to your vascular surgeries in the heart, you have vascular bypasses and surgeries done in the brain as well. And one of the common conditions for which a pediatric neurosurgeon has to do a bypass surgery in the brain is Moyamoya disease. And then again, there are these common craniofacial malformations where you have either a single suture absent, like here you have a coronal suture absent. You see here the sagittal suture is absent with its corresponding head shape. And then you have these other patients where there are multiple sutures which are absent. And these are actually the syndromic craniosynostosis, which are also associated with other features like syndactyly and a cleft lip or a cleft palate. This is a child with Apert syndrome. And then you have all these congenital spinal anomalies. Like in this case, you can see that the cervical spine is so malformed. And in fact, as you see, the brainstem descends into the spinal canal as the cervical spinal cord, and it is completely compressed at this area. So this patient presented with a sudden onset of quadriparesis. In summary, the diseases that are dealt by a pediatric neurosurgeon are very exclusive. They are different. And in advanced countries, actually, pediatric neurosurgical services are exclusive from adult neurosurgical services. However, in our country, we still see that pediatric neurosurgical conditions are treated by adult neurosurgeons, but with hospitals like SRCC, where we do tertiary level work in every specialty, pediatric neurosurgery service also holds its own ground because of the team that is involved, and also because these conditions are very different and need different training and different setup. So with this, I'll try to quickly run through some interesting cases to just sort of showcase what you have to deal with. So this, in fact, was a girl who was, in fact, from Grant Medical College, which is my alma mater, and she walked with a limp since childhood. Although with a limp, she still was an avid trekker. But for the last 2 years, she was having, before she met me, she was having increasing backache. And all of this was being attributed to the stress and strain of the NEET exam, which she had cleared to get into MBBS. And, this is one of the pictures from her clinical consultations. You can see that she always had a limb length discrepancy. In fact, in her childhood, she also underwent brain scans to see if there was something wrong with the brain. But a simple consideration of screening the spine was not given. And as you can see in the spine, she had a tethered cord, a low-lying cord with a lipoma. So basically, this limb length discrepancy was because of a tethered cord. So it is very critical for all of you to remember that when you see a limb length discrepancy, there can be multiple reasons, but when you don't find a cause, always spare a thought for an underlying neural tube defect or a spinal cord disorder leading to the limb length discrepancy. Now, unfortunately, because she had never been counseled about this, and when I made her do the MRI and then saw this, she's never come back for surgery again. But, she's only lucky that she doesn't have a bladder and bowel involvement yet. But it is unfortunate that in today's day and age, children like, children from good families go untreated because the diagnosis is not picked up. Now, there was another 6-year-old child who actually presented to our nephrologist. This was again an unfortunate case. She had a skin-covered swellings, but she used to walk normally. So until 5 years of her age, this child was completely normal. At 5 years, she started having urinary incontinence. But because she was neurologically intact in terms of a motor and sensory function, she, had possibly met a few doctors, but everyone believed that, the bump over the skin was not anything sinister. And finally, when she presented to the nephrologist, the reason for the referral was because she had started developing kidney dysfunction. Her creatinine had gone up to 1.8 and there was gross hydroerythronephrosis. And this is what she had. She had a spinal lipoma. So like you see, it's so unfortunate that a treatable condition, of course, not a simple one, but this can be treated well in a pediatric tertiary level neurosurgical service. But now a neurological disorder, a neurosurgical disorder has gotten transformed into a kidney a failure situation. And this is unfortunate again in today's day and age. So whenever you see a lump or bump or pit or dimple or crater on the back, remember that even if the patient is asymptomatic, this patient needs further evaluation, and most cases will need some untethering even when they are asymptomatic, and hence they should be referred to a neurosurgical center. So therefore, this is how tethered cord can present. They can present with neurological problems like motor and sensory problems, muscle atrophy. They can have only sphincter problems. They can have orthopedic problems. So therefore, a lot of your foot deformities, and we see very commonly, we have pediatric orthopedics department here. At times when the orthopedician is unable to explain why a certain foot deformity has occurred and it is progressive, they find out that the spine screening was not done and there was an underlying neural tube defect. Then you can have your scoliosis, kyphosis, and the spine deformities because of underlying neural tube defects. You can have tonsillar herniations and all these different forms of closed spinal dysraphisms where the skin over the back is grossly normal, except for these small things. Now, going on to the next case. Now, this is again an interesting case of how a treatable condition was neglected because of fear and misdiagnosis, which was, or rather, failure to diagnose at the right age. This boy, like you see, is a grown-up boy. This is at 17 years of age, but this boy was born with bulging eyeballs. You can see all the malocclusion of the teeth. This child would snore practically since the first day of life. And, when he was born, especially with this obvious facial deformity, the parents were counseled, and these parents are educated. In fact, the mother is a professor in one of the universities in Hyderabad. These are educated parents, but they were counseled that this child won't make it. And even if he makes it or survives, his IQ, cognition is all going to take a hit. You won't believe that this boy was possibly one of the brightest boys that I've ever struck a conversation with. He was an avid reader. In fact, he wanted to take up history and literature in his career later. So all the counseling about IQ and survival, which was given to this family, was actually so misplaced. In fact, mother says that when he was young, she used to push the eyeballs into the sockets because, they would bulge out so much. And he would snore every day. He had obstructive sleep apnea, like you understand very well. So in this boy, what we basically did is, we did something called monoblock advancement. Like, this case was a case of Cruzon syndrome. Cruzon syndrome is a syndromic craniosynostosis where multiple sutures are fused. And in addition, the face is also malformed. So because of which, what happens is that the airways are constricted in addition to the shallowness of the orbits and the facial deformity. So we bring the head and the face together as one unit through this process called the monoblock advancement. And we look at him. This is almost 3 months after the surgery. We sent him home with this frame, which is called the rigid external distractive frame or the RED frame. Very few centers in the country who do this. By this, what we are trying to do is every day we train the parents and they rotate these wires which have been fixed to the bones. And this is painless, believe me, even though it might look costly. And gradually, we bring the face and the forehead forward as a single unit. And look at how handsome he's looking. Look at the way the eyes have gone in. And the mother she had tears in his eyes because she said that in the ICU on the first day, he slept undisturbed because we had started distraction already. And because the obstructive sleep apnea had responded to 1 day of distraction. Believe me, we distracted for 2 to 3 months. And on the first day of distraction, he was better. And, you will make out the airways. This is the pre-op X-ray. You see how constricted these airways are. Then we have applied the frames, and now look at the X-ray here with the airways. So they have opened up, and hence the OSA has responded. So these syndromic craniosynostosis cases, again, are cases which need early referral to a tertiary care center, pediatric neurosurgical service, which deals with such cases. Now, this is a common condition, but which led to an unusual complication, which all of you should be aware of as pediatricians treating children with head injuries. So 2-month-old boy fell down from the cot and had a linear undisplaced fracture. Now, I'm sure this is a very common practice this is a very common scan in your practice. A child with a linear fracture like this, you might involve the neurosurgeon, but you know that nothing needs to be done as far as the brain is okay. Now, what happened with this child is the scalp swelling over the fracture resolved over a week, but within 6 weeks of the trauma, the scalp swelling reappeared, and he started developing left hemiparesis, which almost coincided with the reappearance of a scalp swelling. What could this be? This is a condition called growing skull fracture. Look at what has happened to his skull fracture. From that linear fracture, it has now gone on to become this big defect. And you see the brain and the meninges are herniating through this defect. And because of which, this is the right side, he developed a left-sided hemiparesis. Presentation. Sorry, the presentation doesn't seem to be moving ahead. उसको बुला के बिठा के रखो. Yeah. So this is a growing skull fracture. Now, this is a rare complication of linear skull fractures, which can happen in growing skulls. So this is generally seen in infants or in children less than 3 years of age. Now, this is rare, but this is something which you have to counsel all families who come with fractures and who receive conservative treatment under your care, because this is what happens. The meninges and the brain get trapped within the fracture edges, and then they do not let the fracture edge heal, eventually leading to the gaping or the widening of the skull, and the brain there, which gets trapped, undergoes damage. So here, then, therefore, it involves a surgery where you actually go and find the whole dural defect. You see how big this fracture had become from just a simple crack. And then, I had to repair the whole dura, and then again, use his own bone pieces to put a graft, so make a bigger opening. So this required a big surgery, but this child is doing very well. Of course, the deficits which had set in, they responded to physiotherapy, but only partially. So again, what is important in this case is always remember, any child less than 5 years, if you have a CT report which says that the bony fracture is wider than 4 mm, but even if there is not, any child less than 5 years with a fracture, and if you have an MRI which shows dural tear, great. But even if not, any child less than 5 years with a fracture, there is an incidence of 0.05 to 1.5% of a growing skull fracture. So you should counsel this and mention this in your discharge summary. Now, this is again a girl, 6-year-old girl, sudden onset of right-sided weakness. We diagnosed Moyamoya. The neurology team diagnosed and referred the patient to me. Now, Moyamoya disease is a condition where there is chronic occlusion of the intracranial vessels. And, it is a Japanese term where you see, because of the occlusion of the vessels, the brain starts developing these collateral vessels to maintain the vascularity and the perfusion. But eventually, these collaterals don't prove adequate or enough for perfusion, and leading to strokes. So in Moyamoya disease, we do two kinds of bypasses. We do a direct bypass, which is called the STA, that is the superficial temporal artery, middle cerebral artery bypass. This is exactly the kind of bypasses that are done in cardiac surgery. But in neurosurgery, remember, especially in children, the caliber of the vessels is way smaller than the bypass surgeries done in the heart. And then you have these indirect bypasses, which is generally reserved for younger children. So, this is this is that child, 6-year-old. We decided to do an indirect bypass. You see, I've isolated the artery, then I'm opening the dura. Now the brain is exposed. You can see this is the brain. And then we try to graft, or rather suture, this artery to the PL layer of the brain, so that collateral is now growing from this artery into the brain. So this is an indirect bypass, and then we close it again. Now, the next case. Now, this is again an interesting case. This was a 6-month-old child who was diagnosed with a brain tumor, a large posterior fossa mass. They seek multiple opinions, eventually came to us. We discussed in our multidisciplinary meeting, and this was a 6-month-old child. So he was hardly 5.5 kilograms. So in our center, we perform surgeries on children as young as 6 months for so we do, I know shunts are done even in 1-day-olds at multiple places. But operating on a 5.5 kilogram child who practically has, less than 500 ml of blood in his body, doing a brain tumor surgery is a high-risk surgery, both for the surgeon and especially for the anesthesia team, because the child could exsanguinate on table. But that is where, we do this high-risk surgeries because everything is protocolized. We have a team which is used to, for us to operate in such complex cases. So we lost 400 ml, which was practically almost his entire blood volume, but the child did very well. And within 1 day of post-op care, this child recovered. And then you see, this was the tumor pre-op. And I managed to remove the whole tumor, and the child did well. And this was the histopathology. Now, in brain tumors, remember, in the past, and I think even now, I have so many young children, especially children less than 3 years old, who, when diagnosed with a brain tumor, are counseled, one, that the outcome is poor, because generally this was the belief previously, that any child less than 3 years who develops a brain tumor, it portends an ominous prognosis, one. And second, even if the prognosis may be good, but doing surgery on this child will practically kill the child. And so therefore, they are either partially resected or they are not completely resected, and then they're just referred for chemotherapy or radiotherapy. However, we have a holistic pediatric neuro-oncology team here. And in today's day and age, every brain tumor needs to have a molecular diagnosis. So medulloblastoma alone is not enough. So this is SSH wild type TP53, which means that this is a good type of medulloblastoma. It is almost 2 years now since this child was operated. He received, now because he was less than 3 years, he was only 6 months, we could not have given radiation to his brain. So our oncologist did a fantastic job of giving. Now the outcome for this child ranges from 40 to 95%. But the first thing is the tumor has to be completely resected. And that is what I managed. But after that, I referred this, and we plan to do a tandem transplant. Tandem transplant practically means that we do one or more actual autologous stem cell rescue and give high dose chemotherapy, which will possibly deplete his bone marrow completely. And with this this strategy, you see there is this difference. The long-term survival and overall survival of this class of medulloblastomas is very, very different if you take this approach. But doing all of this in a 6-month-old is very difficult. So actually, the oncologist decided to give intraventricular methotrexate inside the brain. So I had put a catheter during surgery inside the brain, through which she was planning to give intraventricular methotrexate. But another important thing, this child, after a few weeks of surgery, developed hydrocephalus. So I had to put a VP shunt. Remember, at our center and internationally, the gold standard now is to not treat hydrocephalus upfront. In the past, neurosurgeons all across would first shunt big ventricles and then decide to remove the tumor completely or partially, depending on how much they could. But now we only put a shunt when the child does not respond in the severity of his hydrocephalus after the tumor is completely removed. So now the question here was that if we put a VP shunt and then the oncologist gives chemotherapy into the brain, all the chemotherapy will drain into the abdomen. Now, this is where we decided that we will put a programmable shunt, which means that with the help of an external magnet, you can switch off the shunt so that the patient is admitted for the intraventricular chemotherapy session. The doctor or the oncologist or the surgeon switches off the shunt, which basically means for 4 to 5 hours, the shunt is not working, during which the drug is introduced into the brain, the drug stays into the brain, and then the shunt is switched on again, and then the patient is sent back home. So this was done for multiple sessions, and eventually we managed to do it. And this child overall has done very well. This is of course an old slide. So, the child then regained weight, the ventricles responded. The child, it's almost 2 years now, and now she's actually a brain tumor mascot of sorts. She has developed her own platform very recently. In fact, she shared a podcast which she did with an international group of brain tumors, talking about her journey, and she's now on a mission. The mother is on a mission to motivating other parents with brain tumors, saying that the prognosis of brain tumors in children is not as bad as it is made out to be. Now, this is another case, a 9-month-old infant, no gaze fixation since birth, practically blind. So she went to multiple ophthalmological centers. Eventually, she had a genetic diagnosis of osteopetrosis. Like, osteopetrosis is a condition where overall there is overproduction of bones, and it leads to, in this case, it was leading to abnormal density and occlusion of various foramen or canals in the brain, which leads to cranial nerve symptoms. The only treatment for this disease is bone marrow transplantation. However, because this child was practically becoming blind. Once she would have undergone BMT, I would lose the window to maybe do anything for her. And so again, here this highlights the multidisciplinary team approach that we take in our hospital. The hemato-oncologist of our department, of our hospital, talked to me, and he tried to figure out whether anything could be done for this child who was possibly losing vision. So if we tried to salvage something, we did a VEP, and we found that there was severe optic canal stenosis. And like you see, optic canals have practically become slit-like. They are 1.5 mm roughly in their caliber. You see how thin they've become. These are zoomed images. And this is a 3D image. This is the superior orbital fissure, but this is the optic canal. You cannot hardly see it. This is one side. This is the other side. They practically become slit-like, and because of which the optic nerves are getting compressed. So we decided that one eye, the VEP, was better. So we will try to do an optic canal decompression. This is possibly one of the youngest optic canal decompressions in the world that has been done microscopically. Of course, I had my ophthalmology colleague who helped me get into the eyeball. But then remember, inside the socket, we are trying to basically drill the bone in the brain through the orbit. So you can lose your way. That is where we use neuronavigation. Neuronavigation is a way of, in a way, it is like GPRS, which tells the surgeon where he is. So you put a pointer on the patient, and then you have a screen in front which tells you where you are. So you know what to drill, because drilling inside the orbit of a 9-month-old can be risky because there are so many vital nerves and blood vessels around. So like I said, this is a child. I'm putting a pointer into her orbit, and then it shows me which way I am, which path I am taking, so that I know that I'm reaching the optic nerve. And this is, in fact, a video, a quick one where you see the ophthalmologist is trying to gain access to the eye, and she is, taking all the rectus muscles control so that she can mobilize the eye for me. And we are going to get in through the medial canthus. So this is like a transcaruncular optic canal decompression. These are, of course, microscopic videos like you see. And so she mobilizes, the ophthalmologist helps me to gain access. Then again, we are, going in through the medial aspect of the eye. And now this is how we drill inside the eye. You see, I'm drilling the bone, but I need to be sure I'm drilling the right bone. Otherwise, I could possibly land up somewhere that I don't want to reach. And also the whole treatment, like you see, we put in a drill. This is a micro drill, and we are trying to drill, and these are dense bones, remember, so that it has to be a soft drilling and in the right direction. Otherwise, you can lose your way in the skull. So we are drilling the medial aspect of the optic canals. So this is what we have done. Now, epilepsy surgery, this is the last bit of my talk. I know Dr. Pradnya has spoken elaborately about epilepsy surgery, but as a surgeon, I would possibly like to present my perspective, which is in agreement with what she has said. We have done around 150 epilepsy surgeries in the last 3 years. We are the only dedicated pediatric epilepsy surgery center in the country. Now, why a surgical treatment for a medical condition? Historically, we all know that a patient with epilepsy goes to a physician or to a neurologist. But the basic concept in drug-resistant epilepsy is that if you really want to cure drug-resistant epilepsy, the answer is not drugs, the answer is surgery. Drugs do not cure epilepsy. Drugs, in my mind, I'm not a physician, but in my mind, anti-seizure medications are like paracetamol. They do not treat the cause of epilepsy. They are only trying to suppress the epilepsy. And so therefore, if you want to help this patient, you have to consider one or the other surgical options if it is drug resistant. Now, what's the problem statement? Generally, 30% of epilepsy cases over a period of time will become drug resistant. That's a very significant number. Now, the question is, in a pediatric population, this is not just about a moving limb or about falls, which are, of course, a big problem for the families or the child suffering from epilepsy. But in a growing brain, this leads to neurocognitive decline, like you know. Plus, it leads to poor quality of life. These children give up school. As they become teenagers, they are afraid to go out. They don't make friendships. They do not go on picnics or camps. They do not continue with their education. And then as they grow up, they do not get jobs. Marriage becomes an issue. Also, all of them who have drug-resistant epilepsy are living with a risk of premature death or SUDEP, which is sudden death in epilepsy. And the societal economic burden, the multiple hospital visits, OPD visits, emergency admissions, ICU admissions, in fact, in the long run, prove to be more expensive than an actual pre-surgical evaluation and surgery if needed. So therefore, living with epilepsy is a psychosocial burden. And this is something that only and only families who are suffering from epilepsy, because it's just not the patient, the whole family suffers from epilepsy. So it's a psychosocial burden which is not talked about much in the society. Now, drugs, like I said, are not anti-epileptogenic. They're not disease-modifying. Hence, they are now called anti-seizure medications and not anti-epileptic drugs. So if, according to the ILA definition of drug-resistant epilepsy, if you have failed to achieve seizure control with 2 well-tried anti-seizure medications, you should consider referral to pre-surgical evaluation. Pradnya has already talked about how beyond the second drug, the third drug is actually, useless. The cumulative incidence that I said is around 30%. These are some randomized control trials which, sort of establish the superiority of surgery over medicine. Now, in temporal lobe epilepsy, like you can see on the left side of the screen, at 2 years, this was a trial by Simon Weib published in the early 2000s. Medical therapy at 2 years gives 0% seizure freedom. Surgery gives a seizure freedom in the range of 70%, which is massive. Now, again, this was a trial from India where they had studied around 300 children with drug-resistant epilepsy. And again, the difference was 7% for medical therapy versus 77% for surgery. Both these trials sort of, in a way, established the superiority of surgery over medicines in drug-resistant epilepsy. Remember, many therapies can offer seizure remission, but only surgery offers seizure freedom. Now, this is again an interesting concept, statistic. This is one of the most underutilized evidence-based treatments in modern medicine. We have now there is a patient for stroke who has already had stroke. We still would go ahead and do interventional procedures on the patient, knowing very well that maybe many effects of the stroke will never be reversed. But still, the referrals for stroke and post-stroke interventions, and stroke I'm just using as an example, are very high because somehow referring a patient for stroke comes very naturally to a physician. However, many interventions don't cure the stroke at all. And here in epilepsy surgery, we are talking about an intervention which can cure the disease. Yet, referral for epilepsy surgery is a major problem all across the world. And a lot of it is also because of lack of awareness in families and doctors treating epilepsy. In US, they are only doing around 3,000, and this is, of course, a statistic from, again, 3-4 years ago. They're only doing 3,000 to 4,000 epilepsy surgeries in a country like US, where there could be almost, 1 to 2 lakh surgical candidates as a prevalence. In India, in 2014, we had around 0.5 million people who were living with drug-resistant epilepsy, and the amount of surgeries that were happening in 2015 were around 400. This might have possibly gone to 1,000 surgeries in a year in the whole country. This is the treatment gap for epilepsy. And this is something that we need to bridge as a community. This is, again, the same thing. Now, Pradnya has talked in detail about the fact that you need extensive workup. Epilepsy surgery, as opposed to all other neurosurgery, needs establishment of a concordant hypothesis before we touch the brain of any child with epilepsy. Otherwise, the surgery will fail. And that is where epilepsy surgery can't be done by a neurosurgeon alone. It needs a holistic team who are both invested in the outcomes of epilepsy and who are trained in the management of epilepsy. Pradnya has talked about all these. These are all the people who are there in our team. We are looking for concordant data and a safe strategy. This is the team that Pradnya has talked to you about already. This is some of the technology we use in imaging, in intraoperative monitoring, neuronavigation, electrophysiology, awake surgery. I'll show you some interesting pictures. Now, this is the kind of, so I had to operate on this area of the brain, and you see corticospinal tracts are emerging from this area. So I have done something called a tractography, which orients me during my surgery, because this is there on the navigation screen. So I'm trying to remove this area of the brain without hitting the corticospinal tracts. Otherwise, I'll give the patient a deficit. And, we disconnect the tracts. And then we also establish on our tractography that the tracts are disconnected. These are the various things we do with imaging in tractography. Now, this is functional MRI. So when we are operating in or close to an area in the brain where we think there is a function like speech or there is a function like, motor function, we do functional MRI, which tells us where that particular area is located in the brain. And that then helps us plan the surgery and sometimes maybe even, call off the surgery if we believe that it's too risky to operate in that area. Then these are some ways of post-processing the MRI, where we are using the PET scans to find out abnormal areas in the brain. This is neuronavigation, which I've already shown. This is basically my GPRS within the brain. Sorry. And this is central sulcus mapping. The interesting bit about this is so these are all sulci. Remember, the brain doesn't come with labeling. Now, I am trying to find a sulcus, which is the central sulcus, which means anterior to it will be motor. Let's imagine this is the central sulcus. Anterior to it will be motor, posterior to it will be sensory. My surgery is such that I should not go anterior. This is anterior, this is posterior. I want to stop posterior to the sulcus, because if I go anterior to the sulcus, I'll give the patient a neurological deficit, a hemiparesis. But how does one tell on the brain? So this is where we do central sulcus mapping. We actually stimulate and try to do somatosensory evoked potentials, and we are seeing which sulcus in between these electrodes actually has the motor potential. And we found out that this sulcus is the central sulcus. And therefore, like you see in the corresponding pictures, we leave this sulcus and we disconnect posterior to this sulcus. Now, if I do this blindly, you can imagine how risky it is and how likely I am to give a deficit to the patient. But this patient woke up with, of course, long-term seizure freedom and no deficits whatsoever. So this becomes very, very critical during surgery. We also record EEG from the brain surface. This is called intraoperative monitoring or electrocorticography. And for this, we have Dr. Pradnya coming in to theater. These are some of the rare surgeries where physicians and surgeons work together, make a plan, operate, test, retest, change plans intraoperatively. This is again a surgery which is done as a team. Though the surgery is being performed by the surgeon, the plans are being made in combination with the neurologist. So we are doing different kinds of monitoring from the surface. This is a grid electrode. This is a depth electrode where we are putting electrodes inside the brain and recording electrocorticography from within the brain surface. Now, this is awake craniotomy. In children, awake craniotomy is not very common because children, of course, can get scared. But in a well-selected child, awake craniotomies are possible, and we do it very well. But you can imagine sometimes adults freak out on the, just on the thought of imagining that they will be awake in the operation theater and the brain will be open on the other side. So like you can see, this child is under anesthesia. What you are seeing here is actually a frame. So in brain surgery, the head has to be absolutely mobile. If there is an awake patient who is moving his head and I'm working close to an artery or a nerve, you can imagine what will be the fate of that patient. Therefore, I have to clamp this patient with pins which go into the skull, which is a painful thing. But the patient is awake. This is where the beauty of neuroanesthesia comes to the play, where we are using techniques where the pain in the scalp and the bone is avoided. And the lucky bit is the brain receives pain stimulation, pain sensation from all over the body, but the brain itself does not have pain receptors. That is why we can operate on the brain and it causes no pain to the patient. So the only pain that we have to deal with is pain from the scalp, bone, and meninges. Now, this is me on the other side of the patient trying to, operate, and she is lying comfortably, calmly on the table with her head fixed to the table. Now, this is, just to show you that I'm drilling with my drill on the scalp. And she is awake. You can see there is no endotracheal tube. So there is no actual general anesthesia. We have only given her some sedation. So this is an asleep, awake, asleep. So when she's this part of the procedure, when I'm doing the painful bit, she's slightly asleep. So you can hear the sound. So the drilling is going on, but she's completely still. So this is the beauty of anesthesia. She's in the asleep phase. And now we go to the awake phase where you can see her eyes are open. We have a neuropsychologist here who has already, we prime the patients. We tell them what is going to happen inside the theater so that they're not scared. They don't freak out in theater. And now we are testing her because I've already operated on the brain. I want to see that I have not caused no damage. So, of course, you can see that I'm a little anxious because I want to ensure myself that she's moving her limbs despite what I've done to the brain. And so I've operated on the right side, hence I'm testing the left side. Very nice. So her leg is intact. Good. Good. अब हाथ को एल्बो से ऊपर करो, जैसे उठा रही थी, करो, मोड़ लो, हाथ को ऐसे उठा लो, ऐसे कर लो हाथ को, करो, गुड, करो, और ऊपर करो, और ऊपर करो. So that's it. After this, I'm relieved that I've caused no harm and she has sustained the whole surgery well, and then we decide to close. Now, these are some other surgeries we do. These are complex surgeries called stereotactic surgeries, where this frame, which is called the stereotactic frame, converts the whole skull into a 3D, like the earth. It converts the skull into a 3D sphere. And every point in the brain has 5 coordinates. Then I have a meeting with the neurologist who tells me that she wants electrodes implanted into the skull to record EEG from within the skull. This is generally done in those epilepsies where we think that epilepsy is arising from a certain area of the brain, but the MRI shows nothing. So there's an MRI negative epilepsy. So like you can see, we have done a temporoparietal occipital implantation. This surgery, this is precisely gone. These electrodes are 1 millimeter or 2 millimeter electrodes, which have gone exactly in areas of the brain where I and the neurologist decided to put them. So this is again types of surgeries that we do here. And then after having put the electrodes, we record, these are how the electrodes have gone in. This is a 3D brain skull. The electrodes have grown in. And through these electrodes, then we record electrical, you see, these are CT and MRI merged images where you see electrodes going into the brain, depending on what hypothesis we had. And then this is the painstaking part where, the epileptologist has 150 to 200 contacts as opposed to a conventional EEG, scalp EEG, which is done. And she has to study all of this. She has to then stimulate areas to reproduce clinical seizures. She has to test function. This sometimes goes on for 5 to 7 days. And the patient sits very comfortably with 14 to 15 electrodes implanted inside her brain, as I showed in the previous slides. And then basis where active spiking or current arises from in the brain. And if it matches our hypothesis, we then decide to resect that area of the brain as stage 2 surgery. Now I'm coming towards the end of my presentation. Epilepsy surgery is of multiple types. Broadly, they can be divided into curative and palliative procedures. Curative procedures are practically procedures which cure epilepsy right on the day they are performed. So if you have an epilepsy which is localized and lateralized to one side or one area of the brain, you can do resections. You can do, if they're localized to multiple lobes, you can do lobar resections. And sometimes if they're involving practically more than 1 or 2 lobes or the whole lobe, you do disconnections, hemispherical lobar. And then when the epilepsy is non-localized or it is bilateral or it is in areas which you can't remove, hence the eloquent cortex, that is when you do these so-called palliative procedures which control the epilepsy. These are corpus callosotomies and neuromodulations like vagal nerve, deep brain stimulation, and responsive neurostimulation. So here it's just a cartoon showing you if you have a local focus, go resect it. This is resection. Like here, there's a focal cortical dysplasia, so we went and removed it. This is a low-grade tumor, ganglioglioma, so we went and removed it. All these patients were seizure-free right on the evening of surgery. Now, when there are more than 1 or 2 lobes involved, that is when we do a disconnection surgery. These are complex surgeries done only for epilepsy. But yeah, we do it quite commonly for the substrates that we deal with. And then you have the whole hemisphere affected. You do hemispheric disconnections or hemispherotomies. And again, this is corpus callosotomy. Corpus callosum is one of the biggest commissural fibers connecting both the hemispheres. So especially in situations like Lennox-Gastaut syndrome, where you have bad generalized EEG discharges, you have regression, and you have drop attacks. The typical LGS picture, that is when we do a corpus callosotomy. So basically, we cut this whole commissure going in between both the cerebral hemispheres and disconnect both the hemispheres. And especially for drop attacks, where children are actually falling and hurting. And I'm sure all of you see such patients in your clinic. Corpus callosotomy works like magic. And, it really improves the quality of life, one, the safety from falling and injuring themselves, and also it improves the cognition, the EEG, and then they're more responsive to therapy. And then again, sometimes we do these other surgeries, which are called neuromodulation surgeries. One of this is the vagal nerve stimulation, where we wrap an electrode around the vagus nerve, and then we place a battery which sends current to this electrode, which then goes to the brain and tries to modulate the brain and control epilepsy in multiple ways. We also do deep brain stimulation for epilepsy, which is akin to the deep brain stimulation that you've heard for Parkinson's disease in adults, just that the targets in the brain are different. And then, like I said, stereotactic procedures that we do. So yeah, so with that's it. I think we have a panel discussion coming up. So we will, I think, quickly move on to that. Thank you very much.
Good evening, everyone. I'm Dr. Shashank. I'm the DRNB Pediatric Neurology resident in NHSRCC Hospital. So we'll be starting off the panel discussion. So the question will initially be open to all the audience where you can put in the answers on the chat, and then the experts will give the answer. So he's a 1 year, 4 month old child with previously normal development, normal birth history, normal development, lost all the motor skills in the past 1 month after cold, cough, and fever episode. Now a child who was walking and almost running has only partial neck control and no trunk control, and has only myoclonic jerks. And he also has deep breathing that was noted by the pediatrician from the past 15 days. On examination in the emergency, he is severely hypotonic. He has few hyperpigmented marks of a healed rash with scratch marks on the extremities. He has a acidotic breathing and he has absent reflexes on testing. MRI done has shown diffuse white matter and spinal cord hyperintensities. Any guesses of what this child could have? So on testing on TMS, GCMS, which showed elevation of acids, which was suggestive of like a multiple carboxylase deficiency pattern, biotidinase enzyme assay was done, and the biotidinase was less than 11%, which was suggestive of a profound biotidinase deficiency. And the treatment is very simple. It is 5 to 10 milligrams of biotin per day, which will lead to reversal of most symptoms. Ma'am, any other differentials that we could have thought of in this condition?
So the clinical syndrome, I'm just going to remove this. So the clinical syndrome is that of a regression, like a subacute motor regression with epilepsy, with additional features. And the additional features are that deep breathing could mean an acidotic breathing or a respiratory involvement, cutaneous involvement in the form of rashes and sort of ongoing inflammation. So I understand the MRI shows whatever it does, but so anytime you lose motor skills, you are sort of thinking white matter. Then you're trying to say if it's white matter, is it the brain or is it as in central nervous system or peripheral nervous system? Of course, the examination will tell you whether it's a UMN or a LMN. Our examination said yes, there's a possibility of a LMN component because the deep tendon reflexes were absent. So now you have a white matter disease which has possibly central and peripheral nervous system involvement with myoclonic jerks. Now myoclonic jerks are epilepsy which come from the gray matter. They are of course not LMN. So you now have a mixture of a disease which can cause gray matter, white matter involvement along with possibly acidosis. So there comes in your metabolic component and along with skin involvement. So then this sort of starts narrowing down your differential as to what can cause white more than gray matter involvement with regression, with epilepsy, with acidosis, with skin changes. And in that list of differential is where biotidinase comes in. So it's not that you just directly get to biotidinase deficiency. We know that this is one of the deficiencies which will have CNS plus cutaneous presentations. And the CNS presentation can be central nervous system as well as peripheral nervous system, predominantly white matter with epilepsy. So this sort of fits in, but it will fit in only once you have sort of narrowed down that clinical syndrome and have headline items which will help you to get to a differential. Important to diagnose this, since today we are talking about treatable conditions. So very, very important to diagnose this because this is the treatment. All he needs is to keep up with his biotin in the long run to at least ensure no additional problems happen. And we are hoping a lot of these symptoms will also reverse.
Okay, now coming to the next case. We have a 2.5-year-old male child, second by birth order, born of a non-consanguineous marriage, coming to us from Uttar Pradesh. He presented to us with a chief complaints of progressive gait difficulty since the past 1 month. On examination, there was a broad-based stance, ataxic gait, and difficulty in getting up from sitting position with tremulousness. So we'll have a look at the video. This is the home video that the parents have recorded. he has difficulty getting up, and even when he gets up, there is a significant ataxia. And he falls. So, what could be the possible differentials with this clinical history and examination?
Given that we have a normal, healthy child till now, and we've come with an acute onset or a subacute onset of a gait difficulty, the dominant feature is ataxia. And the tremulousness in ataxia gives you a feature that you're looking at either cerebellum or sensory issues. If he hasn't had any infection, the commonest thing would have been a cereballitis secondary to an infection, but you've given me no history of an infection, no history of a fever, no history of any viral rash or anything prior to then. And nutritionally, if you look at the child, he looks like he's a little malnourished. Actually, you haven't, in this slide, you can't see when you take off his topi, you can see that his hair is very sparse and his little light colored hair. So I would have thought first for a healthy child with regression, gait and ataxia, I would want to rule out any nutritional deficiency, commonly B12 deficiency, particularly if the family is vegetarian.
Yes, ma'am. So after asking these and after the examination, so the diet history, the child was breastfed till 2.5 years of age, only except few biscuits and processed foods were given. So the complementary feeding was now not started in a right manner, and the examination showed Romberg sign positive, which is quite evident from the video itself. There were no other cerebellar signs, and the child had knuckle hyperpigmentation. So the investigations which we want to do, we did a CBC to look for macrocytosis, a peripheral smear for hypersegmented neutrophils. As ma'am told us, we did the serum vitamin B12 and serum homocysteine. So even at times when the B12 is normal or nearing normal, the homocysteine elevation can be used as a proxy marker, and MRI brain and spine screen. So the result was a vitamin B12 deficiency with a significantly elevated homocysteine. And the treatment, there is no formal consensus on how to treat a neurological vitamin B12 deficiency, but it is always recommended that if the neurological symptoms are severe, it is always better to start with injections vitamin B12. We can start with 1 milligram vitamin B12 given IM for 2 to 5 doses in 1 week, followed by 1 milligram once per week for 3 to 4 weeks, followed by once a month for 6 months. Or we could just give like a loading dose of vitamin B12 with the IM injections for 1 week, followed by oral vitamin B12 of around 1 milligram daily for 6 months. So this is the child post starting vitamin B12, just a single dose.
As I highlighted before, B12 can come with severe neurological manifestations and even mild manifestations. So ideally, dietary history is very important. And, even if you say you're non-veg, very often people who consume non-veg, particularly in rural India, just consume a very small bit of non-veg in the course of the week. They'll have one meal or something, or one piece of chicken or whatever it is in the meal. So they're predominantly still vegetarian. And in this child, I would even study the mother because he's been exclusively on breastfeed so far, though his diet has been very low. There's a very good chance that the mom will also be B12 deficient.
Yes.
So very often when we diagnose the child, we actually put the family also on B12, because if you're vegetarian, the whole family ideally needs B12 supplementation.
Yes.
Thank you, Shashank.
Thank you, ma'am. So next we have Miss A, a 3-year-old girl from a village in Uttar Pradesh. She presented to us for fever from 1 month. All the spikes of fever were below 102 degree Fahrenheit, and since the time it started, they have been gradually reducing over the period of 1 month. She had an episode of focal seizure on the very first day of the fever, and now from the past 3 days, she has been having severe vomiting. She has also started having a cough with post-tussive vomiting. So there is a central nervous system localization, there's a GI localization, and there's probably a respiratory localization with a decreased appetite and lethargy from from the past 2 days. There was no history of headache. Of course, that's not very reliable in a 3-year-old child. No history of vision loss. No history of any cranial nerve palsies, no focal neurological deficit, no documented weight loss, no history of contact that the parents can give with any Cox disease or retro patient. On examination and even on history, the child is completely vaccinated. The child has a BCG scar. The child has a left cervical lymph node of 2 × 3 centimeter, has a enlarged liver, where the left lobe was palpable 2 centimeter below the xiphisternum, and has multiple subcentrimetric inguinal lymph nodes. So what are we probably looking at? Any guesses? Okay, so with this history in the outside hospital, the first MRI was done on 16th Jan. So Saurav sir will be telling us what is seen in this MRI.
So, like you see, with this history of fever, lethargy, and multiple lymph nodes, and the history of seizure, they did an MRI, and you can actually see that there is enhancement seen in the basal areas. If you pay attention to where my pointer takes you. Also, this child has suffered a stroke. There is areas of diffusion restriction, like you can see here in the ADC map. And then this axial T2 image, where you see that the ventricles are slightly up. I wouldn't call this frank hydrocephalus, but having said that, the ventricles are gradually going up, which is not really unusual because by now, after looking at the scan, the team started thinking that possibly they were dealing with a case of TB meningitis. So after which, I think, yeah, this is what they did.
After this, they have gone ahead with a lumbar puncture. The CSF showed 270 cells, that is grossly elevated, lymphocytic predominance, sugar of 58, which is normal, a protein of 35, which is normal. They appropriately sent it for a gene expert, which was, however, negative. The blood CBC was also normal. Still, they went ahead with a provisional diagnosis of TBM, and the child has gone to another hospital. So this scan done after 1 month because the child had persisting fever and has now developed significant vomiting and lethargy.
So yes, now this is where a neurosurgeon gets involved. Of course, if this is TB meningitis, this is something which is managed by a neurologist or a physician. But the picture that is seen here is of progressive ventriculomegaly. The ventricles, like you can see the frontal horns, this is what we, you know, if we also call it the Mickey Mouse sign, where these are like the ears and this is like the nose. And, you know, the frontal horns are rounded. And if you pay attention, you are seeing some amount of periventricular lucency, which in our routine terms, we call it periventricular ooze, which possibly suggests that there is some transependymal seepage of CSF into the ventricles, which denotes that maybe these ventricles are under high pressure and hence do they need something doing. So now this is where the whole situation arises, that the child, as Shashank said, right now overall is okay, gets some occasional vomiting, but is completely conscious, oriented, alert, no focal neurological deficits, but with ventricles which have progressed over a period of time. And of course, maybe there is a tuberculoma which is developing here again. As you can also see in one of these scans, you can see a T2 hypointensia. So this looks like a typical tuberculoma. So I don't think there is any doubt in the diagnosis, but the question is, when do we shunt, or do we really shunt, or do what? So if such a scan comes to you, what should be our next thing? So generally the norm in neurosurgery is that you don't go ahead and shunt every ventricle that is big. Like I showed you in my presentation in tumors as well, just because the ventricle is big, you don't have to stick in a tube into it. So here we tried to find other evidence to see if there is papilledema or not, and the ophthalmologist confirmed that there was no papilledema. So now the other question that the pediatrician was asking me is, can I do a lumbar puncture, and do we need to do a VP shunt? So I don't know if there are any thoughts. If anyone thinks, what should we do? What should we be doing? So to answer the first question, can we do another LP? So generally, if I go back to the scan, around the foramen magnum, I am seeing good space, which tells me that the cranial CSF is communicating with the spinal CSF. You see the spinal cord has begun here. So therefore, this tells me that if I drain fluid from below, around the lumbosacral spine, it won't lead to problems of herniation that otherwise happens in patients with raised ICP, even if there is raised ICP and we are suspecting it, because sometimes even without papilledema, there can be raised ICP. So this is a safe case for lumbar puncture. And in fact, the diagnostic yield of a lumbar puncture will be good here to help aid further management and response to AKT, because AKT is already started. The other thing is, do we do a shunt? So the answer is no. Now, obviously, most of the work in TB comes from India. And this was a publication long ago, which came from the CMC Vellore team, where they talked about a grading of patients with TB meningitis and hydrocephalus. And like you see, there are 4 CMC Vellore grades. Grade 1 is basically GCS 15. Grade 2 is also GCS 15. Grade 1 has deficits, does not have deficits. Grade 2 has deficits. And then gradually, so the grade 1 and 2 are people with GCS 15. Grade 3 are people where GCS is dropping. It is between 4 to 9. And grade 4 is when, GCS is 3 to 8, who are severely comatose. Now, an important thing in TB is that because there is ongoing vasculitis, there are strokes in the basal ganglia, and many of these children could be drowsy, not because of hydrocephalus. It could be because of the vasculitis and the strokes as well. And so even if you do a shunt and you stick a tube in, this patient might not wake up. So that decision of doing a shunt always has to be discussed with the treating physician, discussed with the family. Of course, if there is a rapid decline and florid signs of raised ICP, then you go ahead and do a shunt. But generally for grade 1 and 2, shunts are not needed in most situations. It is the grade 3 patients where, again, shunts may or may not work, but that is who are more better candidates for shunts. So if you see, like if there is a typical clinical deterioration in these higher grades, if there is raised ICP, so you have to find telltale signs to tell you, direct or indirect evidence to tell you that there is raised ICP, and there is radiological evidence of progressive or significant ventricular dilatation, periventricular lucency, which suggests active hydrocephalus. Visual impairment, of course, is a complication that you are trying to prevent by treating ICP. And if the hydrocephalus is persistent, then you still, despite medical therapy, and the patient is progressively deteriorating, then that is when you consider a shunt. But otherwise, routinely, this patient, I have opined that we are not doing a shunt, and I think he just needs to continue with medical therapy. So yeah, I think that's it. I assume in the chat box there is one question about what is the age limit for epilepsy surgery. Dr. Pradnya, do you want to take that question? Well, so there is no age limit for epilepsy surgery, both in terms of young or old. The youngest epilepsy surgery that we have done is around 4 or 5 months old, like Dr. Pradnya was possibly saying in one of her cases. The oldest, so like in India, like I've said, there are so many epilepsy surgery cases which get neglected or not referred when they were children. And so in that case, we are also operating on adults, like who are 25-year-old, 26-year-old, but have epilepsy which began in childhood. So yeah, to answer that question simply, there is no age limit. Earlier, the better. Are there any other questions that... Huh? No other questions. Okay. Good. So yeah, great. So I think that's the end of an interesting session. Thank you for staying on till the end. And I hope that everything that all me and Dr. Anaita and Dr. Pradnya spoke today has possibly helped you get an insight into the work we do, and possibly also helps refine your practice. Thank you very much.